So I just turned it on. This is a good sign.
I think so. Physicians
And we're live.
I think that's important. I was surprised to hear that only 4%. I sent a text to one of my pharmacists back home. Approximately how long does it take to run a PMP? 5 minutes. Anyway, filling 20 prescriptions an hour. You know, when you got to counsel the patient, you got to do all this stuff. It's 5 minutes. So if Andrew's got new software, you know, this thing's coming. Obviously, 8-year-old software is outdated. So, got to be entertaining. I get it with Galesburg, Vermont, or Macomb. Doctors in that area. Yeah. How far are you from Madison? 2 hours? Is that really? So if the prescriber is delegating to his nurse, run a PMP on this radio, or pharmacy to it, it's working. But that's the old system. It's got to be. They're coming in this morning, they're coming in tomorrow. Running for me. I want to see what they've got today. But you're right, pharmacies have to download by state law a weekly report to the PMP program. That's got to be changed. It does need to be changed today. But not all pharmacies have that up there in software. So then you say, well, effective January 1 of 2019, it will be. So then that gives them time to go to their software and say, hey, I need a software update to get this in your program. And I can, every night when I ask for the end of day of business, I'll automatically send that report to the PMC. Yeah, maybe right there. Hey, buddy. Soccer, scouts.
It would be convenient to try them on the same time.
I mean, why can't they just go at the same time? But then
And girls become equals. Okay. Okay. It's just like a girl being a cereal or whatever. If they can pass it. I got 3 daughters.
yes, I am one of 4 daughters.
Yeah, my wife's a strong woman, so my daughter she's already at 6, she's already at 2.
Well, just wait. Mine are adults, so I think they know more than I do. My one's good, but my other one, she's
We'll talk. I got some issues on it. Tomorrow. We'll get together.
Thank you, everyone, for coming back. It's been great to have you with us here. Real quick note for people watching this or live streaming this online, just so you know, the documents that we're referencing here for the morning and afternoon, they are all published at legislative websites. So when we reference something, you have the ability to see it online and find the details further.
Welcome back, and now we're going to get into the nitty-gritty. We're going to have our hospital, the Mercy, come visit with us today. Here's Mike Pollack from the UCS Healthcare. And have them come to the table and have a conversation about what they are doing about this. And also, this is Bart Gay, the Area Substance Abuse Council. So we're going to talk about treatment. We're going to find out a little bit more about what's going on.
Did you guys want?
Yeah. Good to see you. New bathroom. You bet. This is it.
That PMP, you don't want to first night. What I would.
Oh, okay. All right.
Thank you, sir.
Now I have extras if anyone needs it.
For sure. Spread that around. All pharmacies, all pharmacies, all desks. as a proposal, it's like because they put a bear in the cost of this because it reduces their amount. And that's really good. Thank you. Thank you. Thank you.
Thank you for being here.
Appreciate your information.
As we're getting ready, I'd just like to let you know that the treatment facility that I mentioned earlier this morning that I visited happened to be my facility. And it was a wonderful, wonderful visit. They showed me everything they had, all the therapy and the assistance and you know, the wraparound services around their clients. It was a wonderful visit. But the thing I'll never forget, you're standing at the prescription window and seeing the people come in a steady stream, coming for their daily dose. And I always thought that an addict looked like what you would maybe think an addict looks like. It looks like a homeless person, ill-dressed, down and out and everything. That's not true. I have people come to the window that look like those of us that are sitting here at the table. You know, to get their dose so they can go back to work and be able to function as a normal person. It's something that you have this stereotype, and I'm just telling you now, that once you visit a spot like Mike runs, you'll understand that it's everybody that's involved here. Rich and poor, skilled, unskilled, homeless, or a normal, everyday person. But they're all hooked, and they're all having to come every day, 7 days a week, to get their dose of whatever. So with that, turn it over to you folks, and let's hear from Mercy first, and then we'll move right along, okay?
Good
Thank you very
afternoon.
much.
My name is Melissa Springer, and I'm coordinator of Mercy Turning Point, which is a treatment center located at Mercy Medical Center in Dubuque. And I've been a clinician 23 years, and I have to tell you, over the past 2 years, I have been witness to the most intense human suffering that I have ever witnessed, standing by as a mother buried her only child, and again, family buried 2 sons on the same day. It has just been an extremely difficult amount of suffering. The Mercy Health Network has 99 hospitals in 22 states. And you know, when we work with some of our hospitals and colleagues around the country, our numbers pale a bit in comparison to what they're seeing, but the suffering is the same. So the opioid epidemic is a global threat. It's a crisis for our nation, and it has been plaguing Dubuque and eastern Iowa and other parts of our state. And I will say that today my message is of concern and it's of hope. So it's of concern in that we keep being told by federal experts that the eye of the storm is in the Ohio area, moving our way, and that the brunt of this will hit Dubuque in about 5 years. It's a message of concern in that just days ago in Omaha, there was a fentanyl drug bust with enough fentanyl coming in on an Amtrak train to kill 5 million people. So of concern that it's coming at us from both directions. My message of hope today is that at Mercy in Dubuque, we've been facilitating an opioid response team. Representative Eisenhardt and Lundgren have been a part of that as we've worked very diligently and swiftly to combat the crisis in our area. Last April, we had 7 deaths in 1 week. It was a lot and too much for even one family to endure, let alone that many. My message of hope today is that through that opioid response team, we have been able to have medication-assisted treatment services available for our patients. We're seeing patients have a positive therapeutic response to that medication, as was mentioned earlier. They're able to manage their withdrawal symptoms, manage their cravings, They're able to have dopamine increased in their brain. So what we see in patients is that they're able to secure employment. They're able to have improved interpersonal relationships. They have decreased criminal activity and decreased drug use. So we're very, very cautiously optimistic about the role of medication-assisted treatment, and Mike and Barb will talk. I mean, he's been doing it for years and knows those good results and outcomes. So also, we've been training our local law enforcement. There's been a lot of collaboration. We had a $20,000 grant from our Mercy Health Foundation so that we could equip law enforcement. To date, we've trained and disseminated Narcan to almost 600 individuals. We've had at least 10 saves in our community over the past few weeks. These are lives saved with that Narcan administration. Our police, our law enforcement, they're very enthusiastic now, also wanting to carry that for their own well-being, to protect themselves if they would have exposure to a fentanyl analog. We are, the Mercy Health Network, talking with our physicians about safe opioid prescribing practices. We want to wrap resources around physicians. I know right before lunch you heard about the prescription monitoring program. Our goal in Dubuque is to have all 100% of our 535 prescribers registered for that and using that as a tool so that they can prescribe opioids in confidence. Also redefining how we talk about pain at the bedside and having those conversations with patients about the risks, about non-pharmacological ways to manage their pain, and those sorts of things. So again, it's our pleasure to do this work, but we need some public policy and some laws in place to continue to support us as we do it. We cannot have one more death. We just cannot. And there'd be no greater way to celebrate those that have lost their life than for that not to be any more deaths. I'm asking respectfully today that you consider a Good Samaritan law for our state as a recommendation. Many of the deaths in Dubuque would have been prevented had we had a Good Samaritan law in place. We are one of the only states that do not have this, and we know that, that it saves lives. So please, I respectfully ask for you to consider that. Also, we need to make sure we continue to have funding for FDA-approved medications for the treatment of opioid use disorder, and also treatment access. Right now, the prior authorizations for some of these medications lead to deadly delays. So we need to have some conversation around maybe even not even having prior authorization for like Suboxone or methadone or some medications to help patients when they are at their most vulnerable. I would also ask that we consider some sort of longer-term facility for our state that could handle patients with multi-occurring conditions. The patients that we're seeing that are coming in do not just have opioid use disorder. They have mental illness. They have physical complications. These are very complex and symptomatic patients. In a hospital setting, you know, we have the luxury of having physicians and nurses. Community-based settings, I think, have challenges in that regard. But we need to, you know, continue to make sure that we have the resources in place. And we cannot wait 6 weeks, 8 weeks, 10 weeks to get a patient into treatment. I mean, it's literally like telling somebody that's having a heart attack to come back in 6 weeks when your bed's available. I mean, it's just, what we're seeing is patients returning to their communities. They're continuing to be symptomatic. They're continuing to spiral. They're ending up in our jails, and they're unfortunately ending up deceased. One of my patients said, Melissa, when I walk out of Mercy Medical Center, within 1 block of this hospital are 10 known heroin dealers. I mean, this is really what we're up against. So I ask all of you that we continue to build capacity by getting our public policy and our laws in place so that when you know, more of the brunt of the epidemic does hit us, or maybe we'll have our guards up so it does not. In talking with our state opioid authority, you know, we don't want to declare an emergency here. We want to have everything in place so we don't have the numbers like Ohio and Pennsylvania and West Virginia. And I will also say, in working with the medical centers in those other states, we have very effective state leadership here. At the Governor's Office of National Drug Control Policy, and also at our Iowa Department of Public Health Bureau of Substance Abuse, we have very effective leadership pulling in federal dollars so that we can do some of the work that we're doing. Some states don't have that. So there's a message of hope here today. And I'd like to thank you for your time and your leadership in this regard. And If there's anything more I can contribute, I've provided 2 public policy cards. One is for our opioid response team in Dubuque that has city, county, state, and federal representation. The other is from Trinity Health, which is our Mercy Health in those 22 states, and that is our position for lawmakers on the opioid crisis. Thank you.
Thank you. Melissa does a great job with her enthusiasm and her passion for this work. One of the things that we get to do as treatment providers is network together. So you'll hear how these services are similar, but how they're different. There's a lot of communication and collaboration that's happening across the state, though, so we can effectively find ways to treat patients wherever they're living in the state of Iowa. So today I'm coming to share the experience of the Area Substance Abuse Council. I serve as the executive director for ASAC. Our primary location is located in Cedar Rapids, but we serve 5 counties in Iowa. We are only doing our MAT services in our Lynn County office. We were fortunate 2 years ago to obtain a grant from the Iowa Department of Public Health that allowed us to get some experience with medication-assisted treatment services. We are a comprehensive agency, so what that means is we do prevention as well as treatment and recovery support services for our patients. So one of the handouts I gave you today, the longer legal side, double-sided sheet, just explains the entire collaborative approach that we're taking, led by our prevention services, but pulling in our law enforcement, our hospitals, county public health department, and schools to really take a look at this issue, because we realize that treatment is vital, but of course it's not the answer alone. So community education and partnerships have been very important to us in making this successful. One of the key pieces for us has been on physician recruitment. We have our medical director who's involved in treating our patients, and then to expand our base so we could serve more patients, we are doing 2 collaborations. We partner with the Eastern Iowa Health Center, which is our FQHC in Cedar Rapids, and so they'll be joining us with a new provider. And then we also work with the Abbey Mental Health Center and have a provider there where our patients can be seen as well. Our services generally have focused on our residential patients. So we've started our MAT services with our residential patients, but have transferred them to outpatient, and we have taken in some outpatient patients as well to be in our MAT services. We serve approximately 3,000 people a year, and just to give you some scale, we are only serving 40 patients a year in MAT. So this is very small for us, but the experience that Melissa was describing with the patients and the complexity is what we see every day. These are patients that require a lot of case management and care coordination. They're in our offices frequently. We're making a lot of phone calls and contacts to them themselves, but also to collateral people in their lives, so we can stay on top of what's happening with them and help them address their medical condition with their substance use disorder. The reason this became important to us at ASAC, and one of the reasons we were eager to begin the project with medication-assisted treatment, is the increase that we saw in both heroin and prescription drug abuse in our patients. From 2012 to 2016, it's been over a 200% increase in our population. It's not the #1 choice, drug choice that we're seeing with our patients. That still today is alcohol and methamphetamines. But as we watch and talk about this bubble, we saw it occurring in our agency. We saw more people coming into our agency seeking treatment for heroin and opioids, and we wanted to add another tool to our service array that would help them be successful in their recovery. What we see with the medication-assisted treatment services is it really allows someone to let their brain heal, to take some time as they enter into recovery, and to help them stay in recovery. These patients are staying with us and staying in our services longer than other patients, longer in services compared to heroin patients that we had prior, before we had medication-assisted treatment, and they are successful in maintaining their recovery after they leave services with us, the primary services, and they're just staying in with us for what we call aftercare support services. I also provided to you today the PowerPoint handout, which was prepared by one of our prevention specialists. We are doing a lot of community education around medication-assisted treatment. So much of this is just factual, and there's some statistics from our treatment program in our community as well. I mentioned the partnerships. One of the slides towards the end will show to you that we had looked at comparison data from our law enforcement and from our hospitals in terms of overdoses. And so just in terms of the community perception and the gap that was there, so I'll reference, I think it's on page 5. So in 2015, when talking to the Cedar Rapids Police Department, they reported that they had 60 overdoses due to heroin. However, we talked to our hospital and it was over 300. So really for us, it was that piece of getting those folks together at the table who need to be there to talk about this issue, because we had really a different perspective on the seriousness of that. As we look at it today for 2016 for our local area, the number of overdoses in 2016 was 874, and we are on target to double that for this current year. Our patients in our medication-assisted treatment service, the average age of a patient in our program is 32. We have slightly more women than we do men in our treatment program. We see just about 2/3 are heroin users. The others are opioid and or heroin and opioid together. We have, as I mentioned, 3 current prescribers working with us, and that's a large piece of what we do. Is we talk about access to care. We need to make sure that we have more prescribers aware of how they can become involved and helping them understand the needs of a substance use disorder patient so that they can effectively treat the patient along with the clinical care that we provide. Along the terms of medication-assisted treatment, the access to the drugs is very important. We do a lot of Vivitrol prescriptions for our patients, and that's a drug that I have concerns about as we just changed that over from a pharmacy benefit to a medical benefit. So the access to that is a concern that I have. So that because I don't know the details yet on how that will play out, but it will seem that the provider will have to have the...
Explain to the board, to the committee here, the change in designation and how it's going to affect your access to Vivitrol. And who did it?
So currently, well, the Iowa Pharmacy Board, currently today, what we've been using up until now has been our patients are receiving their prescriptions for Vivitrol from a pharmacy, from a local pharmacy. So they're with us. Our provider writes the script. It gets billed by a pharmacy. Going forward, so that's when it's a pharmacy benefit. As a medical benefit, the drug will have to come from us as the provider. So this is a drug that costs just about $1,400 per injection, and you need 1 injection per month. So it will become incumbent upon the provider to purchase and store and maintain the drug rather than it coming from the pharmacy.
So how do you get compensated for that?
I don't know that answer yet. That's not an answer we've gotten.
$1,400?
Correct.
The insurance companies are paying.
The insurance companies are paying for it today.
It's a covered script.
Yeah, I know, but I always heard it was around $475.
No, it's $1,400 to $1,500.
Okay.
And the shelf life's
I don't
about
want to take
18
the
months.
question time away. I just wanted the committee to understand what these changes is going to do on the use of this drug. And then we can move on and we can ask questions about it later.
Certainly.
That's a very, very big deal that just happened.
It is.
Last month, wasn't it?
Just about a month ago. And as I say, I don't know all the details yet because we don't have it. It is covered today as a benefit with the pharmacy. I don't know if that will continue or not, but being as a smaller provider doing this today, we would like to expand and do this on our other counties, but that would be something we have to take into consideration. If we have to purchase the medication ahead of time, store it, and then have it available for patients when they need it.
Before we move on, I have just one more question. Who would have pushed for the change?
It came from the Medicaid Pharmaceutical and Therapeutic Advisory Committee.
The MAC committee?
No, the Pharmaceutical and Therapeutic Committee.
Okay. And why?
I think they wanted provided in a treatment environment. I believe they want it provided in a treatment environment so it's more controlled and the pre-authorizations will be needed. That's the only reason I can think of.
I understand, but the point I'm when I look at methadone, when I look at some other drugs that are used in treatment, they have a habit themselves. But Vivitrol is non-habit forming.
Right.
Correct.
Therefore, the euphoria is no longer present in the individual, and therefore it looks as if we have a half a leg up on moving the person to abstinence if we would use a non-habit forming drug. You know what I mean?
Mm-hmm.
I'm just thinking that there could be a higher success rate on abstinence if you use Vivitrol rather than the other.
There's a certainly individualized care for each patient, and these drugs, methadone and Vivitrol, work very differently. So Vivitrol.
Transportation issues for treatment are eliminated also.
Correct, if you
because
don't-
of the use of Vivitrol, because it's a 30-day deal.
Also, the oral non-compliance. You're not taking a pill every day. So the creative non-adherence that we see with patients.
I heard about this last week. I knew I'd have the pros here sitting at the table, and I wanted to ask them about it and get some specific detail. And I know Mike's got some ideas about that also, and we'll hear from him when he moves in. So I'm sorry I interrupted you.
No, it's great. That's exactly one of the points that I wanted to make sure that you were aware of, because it is a concern for us as we think about how to make this accessible, just for our agency, but as we spread it across the state of Iowa. So, perfect. Thank you for your time today. Thank you for inviting me. I'd be happy to answer any questions, but I think that's a great transition, and we'll let Mike go ahead.
Thanks, Bob.
Just before we move on, so you have a capacity of 40 in your mass program.
Correct. Today we do.
Doesn't that give you concern in sitting in a community of 180,000 and 5 counties and knowing maybe that there are more out there than the 40 that you're serving?
There are significantly more than we're serving, and that's one of the areas. We have a project, one of our offices is in Clinton, Iowa, and we know that's an area that is needed of the services as well. For us, there is a limited number of prescribers that are working with us right now. There's 3 in our community, and all 3 are connected with us. We are exploring options with telehealth as well. As we look at prescribers and who else we can recruit, we're partnering with the hospitals, with the Eastern Iowa Health Center to recruit more providers. As we've shared some of our experiences, I think we've addressed some concerns that providers have had in the past. There's some concern about working with these patients. As you said, Representative Heaton, there's a stigma that's often associated with our patients, and there's a lot of concern about working with heroin users. So as we provide it's taken on the front end, a lot of education and time to recruit prescribers. So we will continue to work on that. We'll look at telehealth as well. This is certainly an area that we want to continue. We want to expand, so funding will be very important for us going forward. Not only for the medications, but for the clinical care, and especially for the follow-up care that happens with these patients. We do a lot of outreach with these patients. A lot of care coordination is what we call it. We're seeing these patients multiple times in a week, especially as they're new to our project. So they're seeing us, they're seeing our physician, and that's something that we need to see continue. It changes how treatment has worked in the past, but the evidence is very clear. As you were seeing in Mercy, we see a lot of success with these patients.
My turn.
No, hold on, Mike, just a minute. So in Cedar Rapids, you have an ACT program. That, you know.
Yes, with Abbey Mental Health Center.
That's correct. Well, you got 2 of them. The county's doing one and Abbey's doing one.
Correct.
So it's behavioral, right?
Correct.
And it involves community living and then those services, support services that these people receive for their mental health issues so that they don't go back and forth to Independence or wherever the acute level care beds are. Try to break that down and do it that way. So it seems to me that if you have a lot of people that are involved in opioid abuse and are in your MAX program, that you want to transition them to the community, if there's mental health involved in the diagnosis, you could use the ACT in the community to provide those support services that your people with addiction could use. that right?
For some patients, correct. With the correct diagnosis and the right match, then that comprehensive ACT team is the right approach. In Lynn County, we have a SIM grant from the state of Iowa as well, and what that's doing for our community is it's a new database of shared collection of service providers, so we can make what we're calling linkages rather than just referrals. So we can make the linkage within the program, and Abbey Center and ASAC are both parts of that project. So we can ensure that once they, whether it's a co-occurring service, so they're with us and they're with Abbey, or it's a handoff service, that they get the appropriate care long-term, correct?
We just need more ECT in the state. So,
It's a great approach. It's a very team-focused, collaborative approach, taking services to where patients are.
having a big argument now, reimbursement needs to be 175, and managed care is only paying 135. So I can't get any new communities until I raise the ante, because my providers aren't going to lose their shirt providing this necessary service. Mike, ready for it.
Okay. UCS Healthcare years ago was a dirty little secret here in Des Moines, Iowa. It was a methadone clinic in the inner city called IUAP that was closed down by the Iowa Department of Public Health. That moved patients over to Broadlawns for a little while, and then a company called Mid-City Addiction Team was incorporated in 1995, and those patients moved back over there, and it was Senator Hughes who had an impact on the ability of that clinic to get funded. That clinic failed, and United Community Services was incorporated in 1997, and that's what you see today as UCS Healthcare. In 1997, there were approximately 82 patients. Well, I know of 2,000, we have 82 patients. There were heroin addicts. The average age was probably 40 to 50 years old at that point in time. Most of them were Vietnam veterans or IV drug users who got infected during the Vietnam era, and they were dealing with those issues with us. But we were kind of I want to say it again, a dirty little secret in the treatment business, because people thought there was a drug being replaced to an addict just with another drug. But over time, research has shown that we began saving communities money, and those addicts were getting better and better and better. Back then, we started a numbering system in the year 2003 when we got our first electronic health record, and our first number was number 100. This last week, we admitted number 2480 something, and that's from 2004, we think, until the current day. Now, in our rolls right now, we have just about 900. I think the census today was 872 as I looked. Patients coming to UCS Healthcare for medication-assisted treatment. It's a little bit of background. If you go to page 2, knowing that in 2008, I read something put out, I think it was by the Iowa Department of Public Health, in response to the Affordable Care Act. It was called a Good and Modern System of Healthcare, and it talked about integration, talked about how we as providers and substance use disorder treatment had to move forward in integrating our systems and be able to treat mental health issues and medical issues of our patients in order to do it the best way. So in 2011, we became big supporters of integration. 2012, we started a family practice clinic on the premises. And in 2017, we rebranded to become UCS Healthcare, and you can see our mission and our vision there on that next page. We try and erase a lot of stigma in the community by being seen. We're seen at different events with our t-shirts. You see a young woman there. Actually, that's our operations person. If you go to the next page, you'll see what all the services UCS Healthcare provides. And we provide most of those services right now in Beaverdale. We're that place on Franklin, the old Stogdell's building that you used to hear about, just past the old Northwest Hospital. We also provide services at this point in time in Ankeny, and we provide services in Knoxville, Iowa. But as you look at all those things that we do, you're seeing a primary care, a family practice doc sitting there with us. That person is one of our nurses now, who's a patient. But our core business has been medication-assisted treatment all these years. In our roles today, as I said, there's nearly 900 enrolled in MAT services. There are another 250 people enrolled today in just outpatient substance use disorder treatment services. Another 150 in mental health and substance use disorder treatment services. And then our primary health clinic has a little over 1,000 patients at this point in time. But what you need to know is that MAT, medication-assisted treatment, has been the core business of United Community Services or UCS Healthcare all these years. Those patients, as the good representative just stated, come from all socioeconomic groups. I drove here, I had an appointment in West Des Moines, so I drove down Grand. Man, we have a beautiful city right now. But you drive through all kinds of socioeconomic groups, and I can tell you each one of those zip codes are represented pretty strongly at UCS Healthcare, along with zip codes from all over the state. People drive for hours to come to UCS Healthcare for medication services. And that's because we're one of the only organizations around that's a true MAT clinic, which is an OTP. An OTP is an opioid treatment program. If you'll turn the page, the definitions are there. And that differs in the fact that the old methadone clinics became licensed as opioid treatment programs. You can see we're accredited by SAMHSA-approved organizations. We're licensed by FDA, DEA. The federal law requires great structure in an OTP. The beauty of an OTP is there's no limits. If you're a buprenorphine waivered prescriber in the state of Iowa, you have a limit to how many patients you can be prescribing that medication to. An OTP can have a prescriber that's not waived, have unlimited patients being prescribed medications in that organization. The organization must have a sponsor, and that sponsor is absolutely responsible for the overall running of the organization and the safety of the patient as they walk in the door. It's a major thing. I want to be very clear on the difference between an OTP and a prescriber. A prescriber in a private practice situation wants to have the structure for their patient. They want to have diversion control. They want to do the tough patients, but it's been being proved over time that they really don't like that patient and don't have the resources available to them to provide that structure. A case in point, Unity Point came to us here in the Des Moines metro area and asked us to take over their Suboxone patients. These are not the nicest people in the world, but they have a disease called addiction, and they're going to do lots of different things in order to maintain that addiction or get what they want and get what they want now. So there needs to be that structure that the OTP can provide. I want to be very, very clear about that. So if you'll flip the page, you're getting a tour of a methadone clinic. That's 5:59 p.m. 2 days ago, or a.m. 2 days ago on 10/12/2017. That's before our doors opened. Those people are standing in line ready to get their medication at 6 a.m. on a Tuesday morning. You can see the parking lot is full there. In traditional methadone clinics across the country, they've always dosed from somewhere at 6 a.m. until maybe 9 or 10 a.m. in the morning, and we used to do that too. It was so people could come in and get their medication before they went to work, so they could function. Okay? We have, through the years, I get to go be a CARF survey across the country, so I get to see a lot of methadone clinics across the country. And there are so many of them that are still dosing the way IUAP would have been doing 20 years ago here in Des Moines, where the patient's coming in for that dose from 6 to 9 a.m., they're plunking cash down for that medication, and they're leaving the organization. We've expanded to be dosing from 6 a.m. till 5 p.m. at night, so everybody has access. If you need medication, we're going to provide it. We have no waiting lists at UCS. We work very hard to have that go away. We will add infrastructure at any point in time to increase the capacity. If you look at the next page, that's 6 a.m. They're standing, these folks let me photograph them at 6 a.m. Tuesday morning, and we're proud that their picture was going to be shown here in front of you today. One guy did ask me if he could moon the camera, and we said no. But you'll see those people are coming, they're not all coming in every day. A person that's getting methadone or Suboxone or Vivitrol, which we offer all the medications available in our facility, as they move through treatment over time, they get take-home medication. They will earn up to 2 weeks of methadone. They can earn up to 30 days of Suboxone. Our concern, though, of having patients just get a prescription and go to a pharmacy and fill that prescription is diversion control, proper medication adherence. I have a prominent defense attorney that sits on our board at UCS Healthcare, and he mentioned to me at the last board meeting he's representing a client that has a prescription of Suboxone from a private practice physician, and he's using that Suboxone to go to work all week, but starting Friday night he's using heroin on through the weekend until he moves into withdrawal on Sunday afternoon, and then he takes his Suboxone again. We also know of patients that are getting their Suboxone prescription around the countryside. They're selling that prescription because they can make money on it for people like that who want to go to work, and heroin's cheaper. So it's kind of a system where we are subsidizing some of the heroin users out there in the world at this point in time. The structure we've found over 30 years in this business is so very important for the addict. It's just very important. Those people in that line are checking in. We have about 540 touches a day that come in the clinic in Beaverdale to get medication or other services that we offer. But the next slide I've got, or the next page, excuse me, is diversion control, and I think that's the most important thing we can talk about at this table. We are asking people to count their pills of their medications that we're seeing on the PDP. We use the PDP religiously in our pharmacy so we can check what a Medicaid patient is getting scripts for, because we don't want them having unlimited benzodiazepines or unlimited other things. So we're going to count those pills and make sure each case is individualized. But it's amazing how people stockpile stuff, and once you hold them accountable, things clear up and the craziness gets less. We do urinalysis at least 8 times a year for every patient who walks in our door. We do have a group of people that are in the service industry, and they will work until 2 in the morning or 3 in the morning, and then they'll sit around their bars and drink and then come in and try and get a dose of methadone at 6 a.m. And that's not a good combination either. So we're going to breathalyze certain patients so they're not knocking down their respiratory system at that point in time. I've already talked about the PMP. If we suspect a methadone patient or a Suboxone patient that has some group of medication that they're taking home, if we suspect there's any diversion at all or it's not showing up in lab tests, we will ask them to bring those pills back into count or that medication back into count. That's adherence. That's medication adherence, and important for everyone. The next page, I just went into more diversion control. The pharmacist on the left is getting ready to count pills for a patient that needs them counted, and we're managing medication across the board. That middle is me standing in our urinalysis bathroom. That's how we're observing every patient. There are lots of ways to fake a test, fake a urinalysis test. We've found cameras are one of the most effective ways to stop that. Before we put in the cameras, or the week we put in these cameras, we noticed that 10 to 13% of our patients were fabricating urinalysis in some way, shape, or form. They're very creative, good people with an addiction, with a disease, that are very creative in how they're going to move forward. The next page, and I can't stress this enough, is individual and group therapy. If you're an addict, you need individual and group therapy if you're on any sort of medication. I was prescribed antidepressants when I was 30 years old, and given the antidepressants, and my serotonin level went up. And 3 months later, I felt better and they went away. But the underlying causes of that clinical depression were still there. When I was 40, I had the same symptoms and was prescribed the medication again. But the doctor at that point in time also prescribed therapy, and lots of therapy. And I was able to work through those issues, which were really the underlying cause of my depression, and get off then the medication after a period of time, and I haven't had an episode since. But it's so important that psychiatrists, psychologists, CADCs, everybody are involved in a therapeutic relationship with the patient, so cognitive behavioral change will happen. You can't get rid of the underlying addictions unless you can change the behavior that's causing them. Again, I cannot stress that enough, and I worry that in a world where we have prescribers in private practice not having those resources to provide that immediately, and the flags to say, you haven't updated a treatment plan, you haven't had a urinalysis, right now at this point in time that we're adding to the problem instead of controlling the problem. At UCS Healthcare, there's crisis counselors available at all points in time. That's the next page. That's one of our crisis counselors sitting in the chair there. There are quiet areas if you need to de-escalate. That's all part of the mental health business, that's all part of the primary care business, and it's all part of SUD also. Am I running out of time? I can talk too long, I apologize. Let me go to the future in Iowa. The Iowa Department of Public Health has just, through the federal government, given us the ability to access some federal funds. They're calling it the STAR grant. We've just all gone through, in the substance use disorder business, we've just all gone through a needs assessment, which has been very telling. We're seeing we have services and prescribers, but we'd like to expand that. But it's a major emphasis needs to happen on education. We need to educate providers, we need to educate caregivers, we need to educate the whole system against the stigma and the issues that we have. I mean, you're going to see your neighbors and friends in my clinic. You may not know it, and you're going to have a preconceived notion to maybe that's a negative thing, and we need to get over that because these people are ill and we need to treat it just like mental health, and we need to treat it just like diabetes. It's that simple. Anyway, there's a strategic plan that we're all almost done with to try and come forward with ideas on how to handle these funds and what we can do to change across the state. Those are the approved strategies coming through the grant you'll see on the right, and they're all pretty effective strategies at helping ameliorate some of the problems. But we at UCS have realized that we want to increase MAC services across the state. So there's a little known law, it was the SAMHSA rule came out in 2014 where a OTP, not a prescriber, but the OTP, which is UCS Healthcare, can put in medication units in remote areas under their OTP license, and we can use telehealth to prescribe out there. The caveat there is those medication units can't do admission and counseling work, and I don't get the logic. So we've decided we're going to put them in the smack dab in the middle of other treatment centers. So right now we have a licensed treatment center in Ankeny that we own that we're going to put a medication unit smack dab in the middle of, and we're going to increase access for northern Polk County and maybe up into Story County and Mason City area for folks coming down the interstate. We have a treatment facility in Knoxville in Marion County that we're going to drop a medication unit into. And hopefully we can use some of these funds to do that, but we'll give more access to Southeast Iowa with that going on. We are talking to a provider in Ottumwa right now to add one there. We're talking to people in southwestern Iowa, possibly Creston, Atlantic, and Clarinda are thoughts in process right now that we're working through. And just various other conversations like that. But we have a solution to open access. We can provide 2 nurses, the medication, the DEA approved safes, and move forward for about $24,000 a unit. And they will be our employees. Everything will happen under our OTP license with the treatment, this all necessary cognitive behavioral change treatment or whatever other evidence-based practice that people will respond to is being provided by the treatment system out there. And we have at UCS Healthcare, through federal and state funds, different funding streams braided so the indigent patient can be helped. We're billers through all the Medicaid and private insurance systems. Most OTPs are not. Most OTPs are cash and go. So that's the difference why we can take care of the patient across the spectrum of treatment groups, and others can't. Just throw that in there. I hope I'm being clear on that difference between an OTP, a medication unit, and a prescriber. Is that clear? Okay. So I gave you a definition of what that medication unit is on the next page. You'd see it looked like that with Corey sitting there at a window. Then I've just talked about some barriers there, that caveat for no assessment and therapy out there. There's just a few simple things, but I think we're all working through them, and I think we may have a pretty effective solution across the state. The last picture I put in there is a gratuitous shot of my granddaughter, because she is 60 years younger than I am, and I gave you my contact information if anyone would like any more information. But I think the major point is maybe in 20 more years, she won't have to be looking at what we're all calling an epidemic, and maybe she can look at it as treatment, like any other treatment of any other disease. That is my hope. Questions? Wow.
All three of you, it's just been wonderful. It's great. Do we have anybody with questions?
I have a question for, sorry.
Bart.
Earlier on you said patients you're treating, reference to opioids, 2/3 are heroin and 1/3 was an opioid heroin combination. Did I hear that correct? Or
So,
I didn't hear the beginning of that.
Yeah, primary, when I looked at those patients that we're serving in the MAT grant, the primary person coming in was a heroin drug choice. And the others have either other opioids or a combination of heroin or other opioids. So prescription drug abuse.
You know, I'm not sure if you know this or not. I'm not trying to ask a leading question, which is come out that way. People don't start off as heroin users. Usually it leads them into that drug. It's a pretty nasty and severe drug. From your patients and those stats you provided, what is the lead-in to? Is it the opioid pill? Is it something else? I mean, if we're going to try to
Well,
nip the bud,
yeah, there
you
certainly
don't know.
is truth in what I think where you're headed into for some of our patients, that they are given first a pain prescription,
Yes.
right? So then they become addicted to that. It becomes difficult to obtain that, and they do a lot of work to try and get that with different providers and different prescribers. But then some do transition to heroin because it is less expensive and, as Melissa's point, it's very easily to access. Now, there are some patients as well in our services who have just used heroin. They have not had a prescription. So it's not a 100%, but more of our patients will have said they started with a prescription pain pill prior to being a heroin drug user.
What are we looking at? Is it like 90%, 80% approximately? I don't want to hold you to a number there, but I mean, like, what is the scope of looking at leading into heroin here we're talking about when it comes to the pills?
I wouldn't want to give you a percentage. I would say the majority, however, start with the pain prescription.
Okay.
For us at Mercy and Dubuque, it's 80% of our 200 patients.
80%?
About 80% started on a prescription opioid that was legitimately prescribed, maybe for a lower back injury, a sports injury. You know, we're really seeing a shift in our referrals to our medication-assisted treatment services. We initially were seeing people coming in for IV heroin use. We're now seeing the little old lady who's taken morphine suppositories for 30 years as prescribed and now has an opioid use disorder as a result and needs some medication to kind of bridge her down so that she can have wellness. So, but it's a very high number, it's a staggering number.
I guess, oh.
As prescribers have learned about the issues, they've tightened up how they will prescribe the opioid medication. And the heroin out there on the street doesn't need to be injected. It can be ingested just like the pills. And folks are finding they're moving to that source because of the tighter rules in prescribing.
One thing you did mention was fentanyl. Is that, are you classifying that with one of the two groups we're talking about? Is it something separate you're seeing? Or, I mean, to answer what your point earlier on Council Bluffs. So the bus in Omaha last week was very real. But where are you classifying fentanyl as heroin? Is it separate out there? Or just tell me about that. Or you see fentanyl?
I mean, we're talking illegally manufactured fentanyl that comes from Asia, Mexico, You know, much of the fentanyl analogs, the carfentanyls that have, you know, Chicago and Milwaukee are large national hubs for that. So you look at where Dubuque sits geographically to those locations. Like I mentioned earlier, we were named a high-intensity drug trafficking area in mid-2015 because we have those drugs coming through those illegally manufactured fentanyl. So different than like a fentanyl patch that somebody would have, or fentanyl that's used in surgical procedures, which we use with anesthesia and things like that. So, but these drugs are very complex. They haven't been watered down much when they come into our area, and they really pose significant dangers, not only to the individual that may be having exposure, but also to our EMS, to our ED departments, to our police departments. And that was partly how we got the buy-in of law enforcement and the collaboration for them to even carry naloxone early on, was for their own safety.
Thank you. Just for community purpose, and one reason why I asked that question is that when they're dealing with heroin out there, it's not our neighbors going out there just starting heroin right away. There's always something, it's unintended consequence to these pills for which gets down that path.
Thank you. We talked a little bit about the stigma associated with it. I know Melissa's always very ruthless about us in Dubuque using correct terminology. There are probably 3 people in this room who know this piece of trivia. I do because my primary degree is in journalism, but the Associated Press style book in June said that media is to stop using addict as a noun because it's not who they are, it's what they do. It's people with addiction, not addicts, because the attitude we're trying to take is these folks are not immoral people trying to be good, they're sick people trying to be well. Last place you'd expect a lecture on political correctness from a politician, but there you go. I'm looking at the barrier related to uncertainty how MCOs and other third-party payers will, or whether they will pay for services. We had a subcommittee last year on a bill. Representative Lundgren and Eaton were on the committee. I was a witness. You had some language in the bill that would expand insurance coverages. It was met with some stiff resistance. And one of the questions I asked, at least coming out of that, was would the representatives of the insurance industry get back to us with the information, kind of a comprehensive survey, what is covered in Iowa by various health plans in various areas, and what is the utilization of these benefits to get a baseline. Still waiting for that report. You and your colleagues may be able to give us insight, and if you can, please do, based on your experience with who provides coverage and what they provide. Maybe you could start giving us a list so we can maybe start some direct conversations with those entities, and obviously the MCOs would be one place where we might have some interest in starting, because all along it's been pitched to us as quality improvement, better outcomes, getting people to the right place, the right time, with the right treatment. And if the coverages aren't helping us do that, then I think we need to know it.
It seems to vary with provider. It's that broad. People, we as a group, well, due to antitrust stuff, we really can't discuss it a whole lot. But we've started a clinical practice group a little bit that is discussing it a little more. And rates for each provider are not understandable and move all over the place. Don't know the criteria, we're trying to find that out.
So it's the inconsistencies, I think, that are of concern. And as Mike mentioned earlier, you know, we need complete reverence in working with patients. No different than a patient presenting with cardiac arrest or diabetes. I mean, we need to welcome these patients in with that same reverence, honoring their sacredness and dignity. And, you know, we're treating physicians, nurses, lawyers, FAA pilots, college students, you know, so the face of what we're treating. But there's most definitely some inconsistencies with the reimbursement culture.
And I'll just start with the issue you brought up to begin with, prior authorization for drugs that they don't need in 2 weeks, they need now. What are the policies out there?
Methadone, you don't need any prior auth.
So I'd be interested in starting to get some more information on those.
So I could certainly help with that as a member of the Iowa Behavioral Health Association. I chair our Substance Abuse Committee. So Our executive director was here earlier, but we'll take that back. I'm headed to our meeting today, and we can pull some information together that we can share as well. I would say in terms of the rates, two things for us at ASAC. One is our rates are low, which would be probably consistent, you would hear with most folks. So we provide, especially on the residential treatment side, to provide residential treatment care to someone, that's an area that we would love to see an increase in that rate, because what we're providing in 24-hour care plus all the treatment services and helping them transition on. And the other thing for us is the length of stay. We're continually doing education with the managed care companies about what treatment looks like in Iowa, as we have a tremendous system set up for residential care, which is not only about detox and crisis stabilization, but it's actually set up to help someone enter into long-term recovery and help them stabilize as they transition back into the community. So that's an ongoing education effort for our agency, which is to say why someone needs to stay in care with us. I will take one quick moment, if I can, to do it, since you opened up the idea of changing our language, as a plug for our agency's website, which is asac.us. It's on your handouts as well. But we had a number of family members and former patients and community members come together to help us create what I think is a terrific video series. So there's one video that runs with a piece from each of them, but then there's 7 separate videos all talking about their life experiences, their issues with substance use disorders, and the language that we're using now to talk about someone who, as Mike said, is our neighbors and friends and anyone else that has an illness of substance use disorder. So take a look at it. I think you'll find it very powerful video segments.
Any other comments from the board? Yes, Senator.
Thank you for your presentation and your information. Appreciate it very much.
Get that mic closer.
I'll just probably talk a little bit more to it.
Pull it out there. Okay, pull the mic out.
Is that better, Dave? All right, thank you. A couple points I wanted to talk a little bit about was polypharmacy. You know, it's obviously an issue that pharmacists are well aware of, and whether a person is dealing with an opioid issue, they also might have chronic insomnia. They might have they're just anxious person, a nervous person. They need benzodiazepines. You know, I mean, those are all part of the puzzle that we're trying to address and look at here. Another one is I appreciate the non-pharmacy therapy. You know, those are very real issues too, and those should, the counseling, whether it's chiropractic help, those are all things that should be considered in the overall package. And like I said, I just wanted to bring those up. I think they're well worth discussing, and like I said, parts of the puzzle that need to be addressed.
It's a really good point, and again, reimbursement for non-pharmacological therapies is really important as well, so that if a patient's going to respond to deep tissue immobilization for their pain versus taking an opioid, and having those conversations with patients when they're in the hospital.
My question just happens to do with youth and youth treatment. With the fact that we have these opioids that are prescribed in our medicine cabinets at home, how many young people, you know, college age and under, are we seeing go through treatment? And I know we've talked very significantly about education, but what are we, I guess, what are your treatment centers doing to help prevent that from expanding? It's just so accessible now. I mean, you know, we've talked, probably a lot of us in this room have been prescribed an opioid for a surgery or pain. Many of us don't have an issue of the addiction, so we don't use them. Some of us know that we need to turn those in and take them to our sheriff's office or another drop-off location, but a lot of people don't. So I guess my question is, how are you seeing youth being treated, and what kind of education are we putting in place to help prevent that?
Well, for our program at ASAC, our medication assisted treatment is only for adults. However, we do have a youth residential treatment program where we serve adolescents, and that's a program that we call CD+. And so kids can actually come from anywhere in the state of Iowa and stay with us to treat their addiction if they're in need of residential care. For our outpatient services with kids, most of our services are co-located in schools. So we have partnerships in our school districts in our 5 counties where we can be in the school and provide the service there for the kids, their families, for teachers as well. On the prevention side, one of the slides here talks about the Iowa Youth Survey. So we look at that data, and there's data that talks about the harm of a drug and the perception of the harm of that drug. And for most of those, with 6th grade level, when we're surveying kids, their perception of harm on alcohol and even tobacco and other drugs is pretty high. But where we see a decrease in their perception is of prescription drugs. So they believe they're prescribed, they're safe, they come from a doctor. So in terms of our prevention and our education, we focus on middle school for that because of that data that we've seen in terms of the prescription. We do a lot with parents and with the drop-offs with pharmacies as well. So for us, it ties together all the way from prevention to the individual treatment, outpatient setting, to the residential treatment as well. While we certainly have had adolescents who use heroin, that is not the primary drug of choice for adolescents in our treatment program. So we have not seen a large number of adolescents to treat at this point, but we are preparing ourselves for how do we do that, having conversations as well.
I would just say we do have some adolescent treatment services at Mercy in Dubuque, and we are seeing a large number of those young adults using opioids out of their medicine cabinets and their grandparents' pill boxes. So part of our work in the hospital setting is again looking upstream and having conversations with people when those opioids are initially prescribed, so they know how to safely dispose of them, and that will help us to decrease the amount that are available. We also in Dubuque have an I Hate Heroin group, and they've just started IHH Children's Group, because we know that there's a lot of energy in in embracing and engaging our youth in our community. And so we're going to be getting into the middle schools with that work and doing a Rise Together project. And I think that's very, very important. And Representative Lundberg brings up a super good point. You know, we need to be going into the middle school setting, younger and younger, and doing some of this outreach and education and prevention work. So, you know, it's much easier to work with them now than to work with somebody that's a full-blown opioid use disorder later. And hepatitis C, we haven't talked about hepatitis C today, but you know, the cost, the surge of hepatitis C that we're seeing with the IV drug use is just very significant. So we need our youth to know those dangers as well.
I know we're running over, but this is good stuff. And I got some questions myself, so I'm going to take liberty and move on to it. So how do you, what does it take to create this OTP? What does it take? You have the only one in the state?
No,
Where are the others?
There are 5 of us, I believe. There's another one in Des Moines called Center for Behavioral Health, which is privately owned. It's not a community-based organization. Okay. They have, I think, 13 or 14 clinics across the country. There is another one in Waterloo area, that's actually Cedar Falls, that's also privately held, the same situation. There is another one in Cedar Rapids, and Marion is an offshoot of the one in Cedar Falls. But Cedar Rapids is another privately held, it's a large corporate office primarily, but it also just takes cash. And then there are 2 other publicly funded organizations on each side of the state. At Council Bluffs, they do a subcontract with BART, but there are IDPH public funds in there to take care of our western borders. And then at Davenport, I believe they subcontract. I'm not sure how that structure is. I can't answer that exactly. But they take care of some of the eastern places there. And the Center for Behavioral Health has a new clinic up in northwest Iowa somewhere, but cash again. They're banking on stigma that people don't want to.
So what does it take to become one?
I used to say about $1 million, and but you have to jump through lots and lots of policy procedure making, hoops of regulations, state and federal and accreditors. You know, with these med units, my hope is that for 24 grand we can go under our OTP license, and that eventually those will turn into OTPs for those treatment centers as they get used to it and get used to the personnel. You know, I don't want to manage that much real estate, but it's got to be a transition. These treatment programs do not know how how to do medication-assisted treatment and handle that patient just like the docs do. It's going to be an education process. Turning Point's getting educated, Barb's getting educated. I mean, there's lots of work being done in that. So yeah, we'll be able to put them in. I mean, 24 grand in equipment and real estate is really what it takes now, and then a whole bunch of hoops. Federal, state, DEA.
So in other words, you can leverage your OTP to, if the Butte isn't an OTP, that is to stop you from becoming an extension of an OTP and continue to do your work and have more flexibility and opportunity what you can do because you've leveraged through an OTP.
Exactly.
Okay.
That's my point.
I'm trying to get the state vision here because earlier I said Southern Iowa has nothing. There's nowhere to go. There's nothing there. And I visited Sioux Falls, South Dakota this last weekend and went to a telehealth hub up there, Rivera, and they're doing substance abuse treatment by telehealth using our new law that we finally the Rules Committee agreed to this last year on pharmacies, remote rural pharmacies. Well, you use a pharmacist in one location, and by telehealth, you can direct a med tech to fill the prescription.
Okay.
They're using that technique in the Dakotas as they address substance abuse in other states. I mean, they're in 13 states. So, you folks, when you see your clients, how many of them, what percentage of your clients, before they became an addict, were eligible for Medicaid? There's a perception out there that these are poor folks. And I've heard 20% nationally were Medicaid eligible when they became addicted. They might become Medicaid eligible after they become addicted, but I'm just, you have the information.
Different states have different rules on that. Some states are saying if you have an addiction, you're Medicaid eligible, and they're paying for your treatment. I know Arizona.
Yeah, after the addiction. Yeah.
Right, after the addiction. In Iowa, that's not necessarily the case, but we also have the block grant funds for the indigent that are used. I'll need to check some data there internally. I have never asked that question. It's a good one. We know that if we can get them in the door and they're at a bottom, we call it in the addictions business, that they're unemployed, homeless, our first goal is to try and get them funded somehow. And typically we've been moving them from an indigent block grant fund to Medicaid. And that's been very good for the patient, very good for the people who are there.
Do any of you in your treatment facilities deal with the issue of an addicted mother at the time of the child's birth?
Yes, we do. We are required by SAMHSA to give the pregnant woman priority into methadone treatment. IV drug users and pregnant women, and we provide full services and try and educate DHS during that time. We also educate the OB docs how to move through the neonatal system when that baby is born addicted to methadone or Suboxone, but it's a very easy withdrawal process, and it's not painful on the baby as if the baby was born addicted to heroin. That's an awful process.
We treat those babies in our neonatal intensive care unit, and it's always been my understanding that that's been one of the largest expenses to the Iowa Medicaid enterprise, has been substance misusing pregnant women that then have babies that are born with withdrawal.
But we can give you success story after success story of healthy babies being born addicted to methadone, but not having all the problems.
ESAC operates the heart of Iowa, so we have a residential treatment program for moms and kids. So one of a couple across the state of Iowa. So mom can move in. We have 36 apartments. They're all 2 and 3 bedroom apartments. So mom moves in. I know you've been up before, Representative Pete, and they can stay in the apartment complex while they get primary residential treatment, as well as we have a halfway house service for them as well. While they're there, mom's getting treatment for her substance use disorder. Child's either going to our daycare, we have a licensed daycare on site, or they're enrolled in school, so they're getting their needs met for education as well, while mom's getting treatment needs. And then we have a lot of what we call wraparound services for the family. So that mom and child are getting other needs met. We're introducing therapeutic daycare into our services with a partnership with Tanager Place in our community. We have other providers come in to take care of primary care and mental health care for moms. We coordinate a lot of services. They're very individualized for the moms, depending on what their needs are and what the needs of their children are. We don't limit the ages or the number of kids that mom can bring into our treatment program, so we're very responsive to what the needs of that family are. And then once they're finished, if they're staying in the Cedar Rapids community, they're eligible to move into our housing, our transitional housing called The Way Home, which was set up specifically for moms and kids who are leaving primary residential treatment to have a home that they could establish where they can start getting good rental history. Mom can be employed, she can be finishing education, kids go to school. If they finish our residential treatment program, then we have a program, we help them with rental assistance for the first 2 months. Because it's difficult to get all of that started, to establish daycare, to get to school, get to work, figure out the transportation, and to stay in treatment as well. So we help them for a period of time. They can continue to receive outpatient treatment services in that, at The Way Home. We have a counselor that's there for them as well.
Is that between you and Four Oaks is doing that?
So we're behind Four Oaks' campus. We lease space from there. We lease the land.
They have a program too.
Their Affordable Housing Network.
No, they deal with both. They deal with both generations. Whether they deal with a mom,
Correct.
Skill sets, coming out of poverty, support the kids, you know, that kind of thing.
It is a similar setup.
2-gen, they call it 2-gen. Nationally,
Yeah.
they call it the 2-gen program.
Correct. A similar system for moms and kids who are involved in child welfare. It's a system similar to what we have for substance abuse treatment for moms and kids.
Just a word to NCSL. If you could make some phone calls to some other states and find out how the insurance companies, the relationship between the treatment community and the insurance companies, I'd really appreciate that if you get some information to it on how other states, what's the relationship between treatment and insurance in other states. Okay, thank you. I'm bleeding to ask. I need some Kleenex. Can somebody go to a desk and get some? Go ahead, Senator. You take it. I think, any other questions?
Okay. Thank everyone for coming.
Thank you for your leadership.
Oh, I want.
Okay. Back on track here. Mr. Berg. Okay. Go ahead.
Thanks. I'll just go ahead and get started here. My name is Ron Berg. I'm the Director, CEO of Prelude Behavioral Services. We operate programs in both Iowa City and Des Moines. We have outpatient programming, residential programming, we have some transitional housing services as well as prevention, all addressing substance use disorder, gambling disorders, and also mental health services. We serve about 4,500 people a year, and across both regions of the state, we operate about 99 beds for both residential services and halfway services. And to comment on an earlier discussion about the waiting time, for the first quarter of this fiscal year, the average amount of wait time to get into one of our residential beds has been 9.5 days. So we do feel like we can get people in fairly quickly. I was asked to talk about the opiate use and the impact in the rural communities, so I'm going to focus my comments on that area. Mike referenced getting up to speed and a learning curve on the MAT services. Barb and Melissa have been 2 years into their learning curve, and myself and other agencies are starting on that process. So I've got a lot to learn and look forward to expanding services here in the near future. As Mike also referenced, the STAR grant, State Targeted Response, that the Iowa Department of Public Health has received from SAMHSA. And so my comments come from our needs assessment process that we convened to address the STAR grant, and tried to gather information specifically from our areas in Cedar, Iowa, Johnson, and Washington County. The input for these comments came from over 200 surveys that we sent out and responded to through SurveyMonkey. Talked with decategorization directors, public health directors, medical providers, directors of libraries, and so on. So really a broad cross-section of the communities provided input on this. And some of the stuff that we learned, I've just put together some bullet points here for you, but I'll just try and run through these quickly. And talking with the Iowa City Police Department, they feel like they've been able to make some significant impacts on the distribution of heroin in the Johnson County area. It doesn't really impact the use. People are more than happy to drive to get their drugs. So, we just need to understand that if we cut off one supply area, people will simply move to try and find or drive to try and find their drugs. Another interesting piece that we learned is that Narcan seems to be a little more available in the urban areas compared to the rural communities. So the first responders quite often are volunteer first responders in some of our rural communities. They just don't have the availability and the understanding of Narcan that we see in our urban areas. And also interestingly, there was concern expressed about elderly in our rural communities from two standpoints. One is for their use of opiates over a long period of time and accidental overuse, as referenced earlier about some elderly using opiates, but also from the standpoint of being victims for theft, either from family that would come into their home and take the opiates out of their medicine cabinet, or from people entering their home to steal them specifically. So two areas of concern for elderly, and they're being a little more isolated in rural areas that came up in our discussions. And it's been alluded to earlier as well. I did throw in here some statistics about the primary drug of choice when people enter Prelude services. We see that alcohol is 38, methamphetamine or amphetamines are 30%, marijuana is at 23, and opiates are down at 8%. So from the patient number, strictly the patient number, it's not an overwhelming number of people using opiates. The problem is the entirely disproportionate deaths that are related to opiates. So that's our concern, is the number of patients that we lose to this drug as opposed to the actual volume of patients coming in reporting the use of opiates. And then I looked at, are we seeing more use among our urban patients versus our rural patients? About 67% of our patients who report opiates live in an urban county, while 70% say they live in a rural county. So really, it's about evenly split between urban and rural counties. And I should note that these numbers, because we operate a residential program, we accept patients from all 99 counties into those residential programs. So it's not just restricted to our 5-6 counties that we provide outpatient services in, but these patients are coming to us from across the state. Also, I just wanted to, as the attention has increased and accessibility or availability of medication-assisted treatment has become more and more available, patients are expecting it. We are not able to provide as much access to MAT in our residential program in Iowa City as we are here in Des Moines. Here in Des Moines, we work with UCS, Mike's program, to try and provide Suboxone to patients as they start in our residential. We also work with primary health care, the federally qualified health clinic here in Des Moines. So we have some other resources here through collaborative efforts to provide some MAT services compared to what we have in the Iowa City market. So we have had people entering services expecting to get MAT, and then when we're not able to accommodate that need, then they do leave treatment and look elsewhere for some other services, which is very disappointing for us and for them and their family as well. I was at a youth conference that the Department of Public Health put on a couple weeks ago up in Ankeny. It was an outstanding conference. The first speaker was from Missouri talking about MAT services. And he made the point in his presentation that in order for MAT services to be successful, it has to have a solid business plan. It just sounded so obvious to hear somebody make that conclusion. So my request is, as we are looking at how we're going to respond to the opioid issues and how we're going to expand MAT, we need to understand that if it isn't financially viable for people like me, it just isn't going to happen over the long term. One of my concerns is when the focus goes off of opiates onto the next drug crisis that comes along, and the grants dry up to provide MAT services, what's the solution going to be in place to ensure that this doesn't just start over again because we haven't been thinking in the long term? We really need to understand what's the long-term viable business business model to make this happen over the long term. So I just want to encourage you to consider that as we move forward. And then the other point that I just wanted to make briefly is about the stigma that has been brought up. In our discussions with people, it's not uncommon for someone to say, well, the physicians should do something, or the physicians say the treatment provider should do something different, or everybody seems to believe that they are doing what we should and someone else should be doing something different. When in fact, I think we all can work better together. I think we all can be politically correct in how we talk about people who have an addiction. They're not bad people. They are people that have an addiction and have an illness, and they need our support and help to get through that. So with that, I will welcome questions, try and respond to them for you.
Just need to ask you your opinion from your experiences. When a person has chronic pain, there are people out there that are on opioids every day, 7 days a week, on and on and on. Some of them they're not in the last stages of cancer. They just have chronic pain. And I'm just asking, are these people who are on that medication for so long, are they addicted at that present time? I mean, will there be withdrawal problems if they would try to move on to opioid medication?
Not being a medical provider, we should have asked the panel earlier about that.
I know, I missed it, so that's why I'm asking.
I would, I think it would depend on the level of dose that they're on, other conditions that they are also dealing with. I would think that there would certainly be some withdrawal symptoms that they would experience. How severe, how mild, I really couldn't comment on that.
In our discussion that I've had, just like in Boston, when we had a healthcare summit there, depends, I guess, on the dosage, but after a period of 8 or 9 days, you're starting to enter the first levels of addiction. It's that dangerous, it can creep on you that much. And so, I have a family friend that's on opiates for pain. It's not a terminal case at all, but she's on them. And she says, I don't care if I am an addict. I gotta take care of my pain. And so, it bothers me.
I think the difference is it's just like any other medication. You can use it responsibly and as prescribed and to manage your condition, or you can go beyond what's prescribed and start creeping into some inappropriate uses of the drug. Similar to other types of medication.
Representative Deaton, I think I can answer that for you.
Speak up, ma'am.
It's if somebody has an opioid use disorder, and they are addicted to that drug, the definition of that is that they continue to seek that drug despite negative consequences, right? With somebody that is a chronic pain patient and is utilizing the same dose, the same time every day, because it is helping them with their pain, are not addicted, they are dependent. And those are two distinct differences that people need to understand. So yes, a person that's dependent on that pain medication can still go through those awful sick physical withdrawals if they no longer receive their medication. And I've talked to many chronic pain patients that are very worried about that, given the restrictions that are coming down for the opioid pills, and they're a bit concerned. So they are dependent. They can still have those same withdrawal symptoms, but they're two different things. Just kind of like this gentleman said, the person that's dependent because they're being medicated for pain is like taking your heart medication. It's like taking your insulin or anything else. So I hope that helps.
It does so, because I know that as we work towards some type of legislation to deal with this, we will be talking about that very thing, about the difference between addiction and dependency, and where it ought to sit. So I'm glad you brought that up.
It's the same with babies. They're not born addicted, even when their mother is utilizing Medicaid. I call it opioid-assisted treatment. I like that better. But they are born with neonatal abstinence syndrome, so they are going to have a little bit of a transition once they're born. So those are two different things that I think because of the language is very important. Because you know my son died of a heroin overdose, and it's hurtful to have your beautiful, lovely child referred to as an addict. But someone with a opioid use disorder, that's the truth. So I think it's very important with our terminology that we learn those subtle differences when we're talking about these things, especially our journalists and our media too, so that they tell the right story when they talk about what we're doing here. I think it's really, really important to make those distinctions. And thank you for your time.
Well, I appreciate it. Thank you. Are there any other questions for our man from President? Yes, go ahead.
I just have a quick question. You talked about a solid model for sustaining MAT. What does it typically cost for a person to enter a residential treatment program with the medicated assisted treatment? Just a ballpark.
Well, so for the patient themselves to come in?
Mm-hmm.
Well, as I try to develop that model, I could be able to answer that better for you. Right now, if somebody wants to walk into our residential program and they don't have any source of income, they're not enrolled in any health coverage, it'd be about $5 a day in our sliding scale. And they'd be there about 20 days, and we would apply for food stamps to help them pay for that. And then the MAT services would be on top of that, and I'm not able to tell you the cost of that in addition to the...
But that would be their cost. I'm looking
cost.
at what a treatment center's cost would be.
That would be, for the residential, that would be in the area of $250 a day for us to operate that. I mean, when you're in residential, you're getting 50 to 55 hours of direct service each week. We've got 24-hour staffing, providing all the housing costs. There's comprehensive list of services that are provided to everybody in one of the residential programs across the state.
And it appears that people that go through a medicated assisted treatment program have a much better success rate over longevity. Okay. So really, in essence, it can save money.
Yes.
Yes.
Thank you, Representative. One issue. Earlier today, I talked about this issue being a public health matter, not a law enforcement matter. But we need law enforcement at the table as part of community-based coalitions for change. And we've been talking a lot about reaching out to people with addictions to help them. But we got to do that in a way that doesn't look like we're somehow surrendering the war on drugs, which is a difficulty for law enforcement. So my question is, given that there's so little treatment access in rural Iowa, and therefore maybe not as high a level of awareness, what have been the conversations in the areas you do serve between treatment personnel and law enforcement about the response to the issue in their rural areas?
Sure. Well, I've had more conversations with Iowa City law enforcement than I have the other rural counties, and I can tell you, working with it was Iowa City Police in this instance, they approached us out of frustration for being called to the same address numerous times for an opiate concern, and feeling that those patients were not getting engaged in services. Now, what we learned is that they had been involved with us and then not, and kind of back and forth. But we worked out a process with the law enforcement. When they would go to a site, they would give the person that they were called to assist an option of accepting a written charge or signing a release and coming down to Prelude and getting involved with services. Had minimal success with that, frankly. I think it's something that we'd like to continue working with them and see how we can make some improvements. But in our conversation and my assessment is that law enforcement is working on the same issue we are, just from opposite ends of the string, if you will. They don't want people to be harmed with this. We don't want people to be harmed with it either. So I see a lot of overlap between what we're trying to do and what law enforcement is trying to do, and it's working out some of the processes to really highlight that to the benefit of the person.
Any other questions? Thank you very much.
Thanks for your time.
I think we're at the point of schedule now where we should be having our break. Initially it was for 15 minutes, but just we've gone over a little bit. We can all try to be back here at 10 minutes, 2:52. That'd be great. Thank you.
We've invited our managed care companies to come to see us today to talk about, I think, the relationship between the managed care and Medicaid and our managed treatment and so on and so forth. So if you'd like to come up, I'd like to have Eric Bailey with Anthem and Kellyanne Mike McGrory with United Healthcare, Victoria Sharp with AmeriHealth Caritas, and spend some time and talk to us a little bit about where you all fit into the treatment of opioid abuse and what your role is.
First of all, my name is Eric Bailey. I'm representing Anthem and our parent company, AmeriGroup in Iowa. I do have a couple of local folks that are in the room with me. Dr. Kelly Pennington and Kyle Carlson, who as local questions come up that I'm not able to answer, we'll certainly take that opportunity to take those back and get back to you on those with those answers. First of all, I'm no stranger to Iowa. My mother grew up in Mount Pleasant. My grandfather was a small town physician in Mount Pleasant for many years. He grew up in Traer, Iowa, and his parents operated a pharmacy there. So Iowa has always been near and dear to my heart, as is the Midwest. So I do represent Anthem from a national perspective, so I will be focusing a bit on our national efforts, but certainly trying to infuse a bit of what we've noticed in the state of Iowa as well. So I think it's safe to say that from a national perspective, we're facing an epidemic of unprecedented proportions, and I've been in this field for 20 years. I've never seen anything like this. You know, I've been a clinician, both as a substance use disorder clinician, as a mental health crisis clinician. I've worked in several different types of environments, and this is something that has drawn profound attention. The release of the Surgeon General report last year is a strong testament to that. A positive outcome of that is that it's drawn attention to the need to refresh how we approach substance use disorders as a chronic condition state, and it's really put us in a position where we're looking at the types of treatment that we're offering, and it's certainly drawn attention to the types of treatment that we're offering for the treatment of opioid use disorders. So with all of this, I'll include a personal story. So a couple of years ago, I was put in a position to help shepherd our initiatives related specifically to the opioid epidemic, a rather daunting task to say the least. But I jumped in with both feet and began to pull together just about anybody I could within our organization from an interdisciplinary perspective, including representatives from pharmacy, from our commercial business, from our government business, across the board. On one of these afternoons, I telecommute from my home office in Moorhead, Minnesota. I was on a call. I noticed a lot of emergency traffic happening, you know, sirens blaring and so forth. And while I was on a call talking about access to medication-assisted treatment for our members, ironically enough, I noticed the paramedics pull up to my neighbor's house. They ran in, and I thought, oh man, I knew that I had a neighbor that struggled with opioid use disorder, and I knew that she had been recently released from an inpatient skilled nursing facility. Sure enough, about 20 minutes later, the coroner showed up, and my neighbor was brought out in a body bag, a victim of a heroin overdose. It was probably laced with the fentanyl that had made its way to Moorhead that week. So nothing short of profound. What I took from that was a renewed drive to do whatever we can within our sphere of influence within the health insurance industry to address this epidemic. I was also left with a profound respect for the first responders and the way that they responded to this particular incident with a sense of compassion and urgency. Someone had mentioned earlier the importance of bringing together law enforcement and local officials, community-based health organizations. I can't punctuate that enough. It's so very, very important that everyone come to this table. We all have a role to play. So some of you, I do have access to the PowerPoint that I put together. If you don't, I believe it is online. You can follow along there. But from a national perspective, again, to punctuate, this is an epidemic of unprecedented proportions involving a significant increase in opioid overdose deaths from 1999 up until our current date, with no signs of really slowing, particularly with the heroin epidemic. The rate of babies born with neonatal abstinence syndrome has increased fivefold from 2000 to 2012, which is something that we're addressing as an organization. So, we could probably spend hours talking about the impact that it's had from a national perspective. But in the interest of time, I think we'll take a look at specifically how is this impacting Iowa. So when we think about the way that an epidemic like this can impact various states across the country, in Iowa, this comes from the CDC, so there's been a 7% increase in drug overdose deaths between January 2016 and 2017. So,
that number again?
What's that?
Number again?
Sure, a 7% increase in drug overdose deaths between January 2016.
Increase.
Increase, yes, sorry. 87 of the 324 deaths are attributed to natural or synthetic opioids. So synthetic opioids, an example of that would be fentanyl. So that's something that's definitely, I think it's been mentioned, but the opioid reversal agent naloxone has very little effect on someone who is overdosing on fentanyl, despite numerous applications and attempts to revive somebody who's taking fentanyl. Extremely dangerous drug. So where does that leave us? From the perspective of what we're doing in terms of I mentioned again our sphere of influence, our organization is committed to taking a leadership role in this particular space from a national perspective. And one of the things that we identified early on was a commitment to reducing the amount of opioids dispensed among their members by 35% from historic peak levels by the end of 2019. Recently, we actually adjusted that because we met our initial goal of a 30% reduction in opioids dispensed early. So we ratcheted that up and are raising the bar a bit in terms of what our efforts can do to address that. Another thing that we're committed to doing is to doubling the number of consumers who receive behavioral health services as part of medication-assisted therapy for their opioid addiction. So we've talked about medication-assisted treatment, and I believe there was one individual who punctuated the importance of, it's one thing to have methadone or Suboxone, but it's extremely important to make sure that's a part of a package that includes behavioral health support services like counseling, group counseling, the support that they need to really launch into long-term recovery. We're also committed to supporting providers in their care of our members, recognizing the importance of patient engagement, prescribing practices that balance treating chronic pain while minimizing risks for misuse and diversion, which is another element that's been broached. So, with respect to the kind of an influence an insurance company can have, one of the things that we really grappled with was where are we going to have the most impact? So we fairly quickly settled into three prongs that we really focused on. First of all, prevention. Certainly doing things to mitigate the train from leaving the station in the first place. We have a lot of opportunities to leverage data analytics and so forth to help us do that. Treatment and recovery. What are we doing in our provider network? How can we increase the availability of medication-assisted treatment to the patients in the country that need that and the markets that we serve? And how can we not only help them get the treatment to begin with, but then also to sustain that from a condition care point of view. So in other words, that long-term recovery that doesn't happen in a period of 30 days or even an extended 90-day period of combination of residential treatment and outpatient types of treatment. This is a commitment that takes a long time to get things pointed in the right direction. And lastly, deterrence. Someone touched on this a little bit in terms of what's the role of law enforcement. Well, from a health insurance company, we can take a look at our pharmacy analytics to help us make some decisions as to do we have some outlier prescribers, for instance, that we can identify that are in need of intervention to address potential pill mills that are going on or unsavory prescribing practices that we can actually then in turn turn over to our special investigations unit when that's appropriate. And there may be other times where provider education and a combination of an SIU approach are important. So for years, the effort for prevention has really included the dissemination of pertinent prescribing concerns directly to providers and supplying them with information related to prescribing practices which could lead to unintended consequences. So one of the things that we've launched fairly recently is a letter campaign to providers to let them know, are they falling outside of the prescribing practices of their peers? And if so, what are some of the things that they can do to address that and rein that in? So not only that, but also we do have ways of letting providers know, for instance, when they have patients who are on multiple medications that put them at risk of an increased risk of overdose, such as being on a prescription for benzodiazepines, opioids, and skeletal muscle relaxers all at the same time. And unfortunately, providers don't always know that. So they can get that information certainly from the prescription drug monitoring program, which is an extremely important tool. But being able to get that in a number of different sources in a number of different ways can be an important way of turning that around. With respect to treatment and recovery, we've been really working on collaborative relationships with various providers across the country. One example is Hazelton Betty Ford. We're working on a unique relationship with them. Incidentally, this is an organization that's well steeped in 12-step tradition, but recently has added an element of medication-assisted treatment to their Core 12 programming. So if Hazelton Betty Ford can readjust and refresh the types of services that they're offering, then many other organizations can do the same and learn from what Hazelton Betty Ford has been doing. Another good example of something that we've been doing to reach into our rural and chronically underserved areas is we've got a partnership with an organization called Bright Heart Health, which offers telemedicine medication-assisted treatment, including the counseling and the monitoring for the Suboxone maintenance.
What's that called?
They're called Bright Heart Health.
Right Heart?
Bright.
Right.
Yep, as in B as in boy. So that's another organization that's really pushing the envelope. And again, in some of our markets, I'll use Kentucky as an example. There are some extremely remote areas. Kentucky's been a state that's been very hard hit by the opioid epidemic. This is an organization that can help us reach out to members and patients who live in otherwise chronically underserved areas that simply don't have access to some of the specialty care that they need. And again, I mentioned with the deterrence piece, partnering with our special investigations unit and making sure that we've got the tools in place to help work with our providers that are falling outside of the norms with respect to prescribing practices. So in terms of the kind of impact that Anthem has had and our affiliated health plans across the country, one of the things that we've done, I mentioned earlier, that we've met our initial goal of reducing the opioids prescribed by 30%, and we've readjusted that to 35% goal for 2019. One of the things that's contributed to that is a point of sale edit that limits prescriptions to a 7-day supply for new opioid starts. So if someone's starting a short-acting opioid, so there's a difference between a short-acting opioid and a long-acting opioid. For the short-acting opioids, they're limited to a 7-day supply when they go and use their pharmacy benefit. For long-acting opioids, there's a pre-authorization process that's in place for new starts to demonstrate that other methods have been tried before going the opioid route. So by tightening some of that up, we've noticed that in a variety of our markets, I'd like to use, for example, in Virginia, we've already noticed a 29% reduction in 29%. In Maryland, for our Medicaid plans, it's a reduction of 22%. And in some of our employer-sponsored and individual plans, we've decreased by 23% in Nevada, 17% in Connecticut, and 17% in Wisconsin. I will point out that Iowa is a bit unique for us in that our pharmacy point of sale edits don't actually apply because of state law prohibiting us from setting that 7-day rule at the point of sale. But despite that, we've still managed to notice an 11% reduction in the state of Iowa with respect to our AmeriGroup business in Iowa, which is a testament to our working with providers and the education efforts that go beyond what we would do at the point of sale. So lastly, I would add that these reductions on the surface are exciting. They tell us that you know, we're turning things in the right direction, and I would add that this is not, these point of sale edits are for new starts. They're not meant to interfere with people who have been on a regimen of opioids that's working, or you know, they're being treated for chronic cancer pain, for instance, or HIV. But these reductions have literally translated to thousands of less pills that are ending up unused in people's medicine cabinets each day. And I'll say that again, each day there are thousands of less medications that are ending up unused in people's medicine cabinets. And as it's been mentioned prior to this panel with the providers that were speaking earlier, that's a big step in the right direction, because oftentimes what would lead people to heroin would be starting with experimenting with either using or abusing someone else's medications that weren't prescribed for them, or obtaining those certainly on the black market. So I'll stop there and turn it over to my colleagues.
Thank you so much for the opportunity to come here today and talk. My name is Kellyanne Light-McGrory. I'm the Chief Medical Officer for United Healthcare for the local Medicaid plan. By training, I'm a cardiologist as well as a palliative care and hospice physician. And so I've had quite a bit of experience over the years dealing with folks who are living and dying with chronic pain. You know, United Healthcare has been in this state for over 30 years in various different roles. Obviously relatively new to Medicaid, as we all are. But we've always been very committed to the health of Iowans. We have recognized for quite some time the importance of our role in helping with the opioid crisis. As a major payer in the United States that has a great access to data, to expertise, it's really our responsibility to take a leading role in helping to identify ways in which we can contribute to the reduction of opioid misuse and an improvement in the health of Iowans. As a group, United Health Group has looked at this not just for Medicaid, but across all of our lines of business, so our commercial products, our Medicare, because we recognize that sadly, opioid misuse is not limited to one group of patients, although as many of you already know that the Medicaid population is at great risk, more so than almost any other group, for developing opioid use disorders and for suffering the consequences of them. Even when we start talking about maternal health issues, the number of babies that are born to Medicaid moms and onto Medicaid assistance is quite high in this country. And so we really have an opportunity to have a pretty strong impact. As you can see, I've provided you a copy of our presentation as well as a white paper that's really dedicated specifically to the work that's being done for United Healthcare in the Medicaid space. Really what we've decided is that over our next 2 years as a group, our goals are to really improve our compliance and our providers with the CDC opioid prescribing guidelines, really getting us to a compliance of at least 75%, if not higher. Really ensuring that we're getting as many patients as possible into MAT programs and increasing that by 50%. And really increasing education among our providers, our staff, our partners across the state about how we can attack this problem. As we go along, really our strategy has been very similar to our counterpart with Anthem, in that we realize that really needs to be a framework to this. It can't be one prong of this approach. It really has to be full and all-encompassing. So ensuring that we're working towards prevention. And for me, prevention is a multitude of things. Education, by and far, one of the greatest pieces of this. Identifying providers, identifying members early on so that we can intervene before we're facing somebody with a substance use disorder. I think developing those partnerships with our providers, I would be hard-pressed to find a provider who isn't trying to do the right thing for their patients. But we have an advantage of having sometimes line of sight on information about where their members or where their patients are seeking treatment, who they're going to, where they're getting their prescriptions, and able to see things in a way that a provider who's in an office may not always be able to see. So how do we really leverage that information, bring it back to our providers as local physicians going to local physicians and saying, hey, this is what we're seeing as we look at your use of opioids. These are the types of people that you're treating, the types of diseases that they have, the quantities of medications they're receiving, and coming to them as partners, trying to help to ensure that they understand the impact of opioids and what it's having in Iowa. We know that Iowa is not by far the worst case scenario for opioid misuse, but we know that it's one of the fastest growing. So how do we really try to get ahead and partner with our providers in order to reach them early and reach our patients early? When I think about this, it's really also developing those strategic partnerships around our communities to figure out how we can really build that foundation to have success across opioid misuse. Other pieces that I think are very important to this are how do we pivot and use all of our pharmacy solutions to the greatest ability that we have. Currently, we have a clear understanding of what every one of our providers is prescribing across the state and have engaged in person-to-person. So whether it's a phone call or myself actually going to the office to sit down and have a conversation about their opioid use, understand what's driving it, what type of patients they're seeing, how we can be helpful in that. Where they may see opportunities that we can develop better strategies for these particular members as well. By virtue of the complexity of their lives, Medicaid members require sometimes an extra touch, an extra amount of wraparound services. How do we ensure that the services that we're committed to are really integrating behavioral services as well as medical and looking at some of the social determinants of health that may also be impacting, making sure that our providers and our members know what we have available and that we're here to be partners with them. In other ways, in terms of prevention, using our provider system to measure and monitor prescription use of opioids. So for example, as we're doing rounds on our patients who are in our various case management programs, we're actually pulling their PMPs and looking at their current opioid use and then communicating back with their primary care doctors or potentially their behavioral health providers to try to close some of those gaps that may exist on individual patients while also trying to work on the population. So I think really it's a critical piece of figuring out early on how do we look not just at the individual member but as well as the population and increase the ability of our providers to be able to reach the people that need to be reached. As we move on and start talking about opportunities in and around treatment, I think there are a lot of opportunities here. And again, we've always committed since we came into the state and Medicaid to truly be whole person care for our state and for our members. So really wrapping around medical, behavioral, and work around social determinants of health. I think most critical, and I think you've all been speaking to that already, is how do we work together to really expand our MAT treatment programs? How do we reduce those barriers? How do we get people to where they need to be? Sometimes it can be things as simple as helping to arrange transportation, figuring out what are the obstacles for those individual patients, and we have that ability to do that, and we're already doing that. We have folks that are going out into the community health workers that live and breathe in their communities, that understand the barriers that they may or may not have where they live locally, so that we are ensuring that they're getting all of the services they need in a timely way. I think that's one of the really important things to realize here is that we really, while we have the advantage of having all of the great stuff that United Health Group has as a national organization, everything we do has to be Iowa, because Iowa has its own unique needs. We have our own unique situations in our different counties, so how do we make sure that we consider that every step of the way and ensure that we're getting that local touch and bringing providers and members together locally. As we move through and we really start to talk about recovery, it's really about, as we've said, an interdisciplinary team. So we partner our behavioral health teams with peer support specialists to help work one-on-one with our providers who are dealing with substance use disorders. We create collaboration with our housing specialist who's on our staff and also has close working relationships with folks in a lot of our shelters, where a lot of our folks are dealing with some of their substance abuse disorder issues. Making sure that as we have people going through treatment into recovery, that we've taken care of some of the other things that can lead them back down that road of recidivism. So ensuring that they have housing, working to help them find opportunities around job support, and helping them to get back to being productive members of their communities and of their families. The last piece that we really want to also focus on is really around harm reduction, and how do we ensure that we are getting folks the things that they need, such as naloxone coverage. As we know, this is covered in the state. It's our preferred treatment on our state PDL. We have a good access to Suboxone and other recovery medications. How do we make sure that everybody who needs that is getting it? How do we follow anybody who's on those types of recovery meds to ensure that they're not also obtaining opioids? And again, using our data to help inform our providers and make sure our patients are as safe as possible. Again, as an organization, we've gone through and identified some of our highest risk areas across the country as our initial pilot programs. Some of the states that are dealing with some of the greatest amounts of opioid misuse is our initial first sort of 10 cities, so that we can then take that knowledge and apply it across the board to all of our Medicaid markets, so that we can all benefit from that shared work that we're doing as an organization. And then again, also, how do we find community partnerships? And I think that's really key. As a local organization, we're taking, again, the overall opioid strategy of our entire United Health Group, looking at what we're doing across the country in our Medicaid markets, but then it's really about creating what are we doing in our Iowa plan. We've created a multidisciplinary group that is just an Iowa-based group. We're bringing together our own in-house, myself as Chief Medical Officer, our behavioral health coordinator, and our maternal health coordinator as well. Folks in our network who can help us to develop even more relationships with other providers around the state and encourage them to develop MAT programs. Working with our pharmacists and our case managers so that we can identify people early and look for other opportunities. We have worked on provider and member education. For example, our upcoming provider newsletter, which we send out quarterly, is featuring information for our providers on opioid abuse disorder. What are our opportunities for them to get more education? For the practicing providers, sometimes having that ability to figure out where to go and where to get information and how to really get themselves more knowledgeable is really a hard thing to do when you're trying to run a busy practice and see a lot of patients. Creating our own network partners and looking for ways that we can also partner with some of the community opportunities, for example, for medication return so that we can continue to work to get some of those pills off the street, out of those cabinets, and prevent folks from picking those up to start with. So I'd like to end there, and if you have any other questions, please feel free.
And let the other ladies
Yep.
start.
Good afternoon, Senator Dawson, Representative Heaton, and the members of the committee. Thank you for the opportunity for me to address you today on this extremely important topic. That we are gathered here today is further proof that the legislature, the governor's administration, along with DHS, the MCOs, and many others are committed to proactively addressing this epidemic that impacts all Iowans regardless of their geography, age, ethnicity, or socioeconomic status. My name is Victoria Sharp. I'm a physician and Chief Medical Officer at AmeriHealth Caritas, Iowa. In addition to my role at AmeriHealth, I am a clinical professor of urology and family medicine at the University of Iowa Carver College of Medicine. I'm one of 3 physicians elected to represent Iowa physicians at the American Medical Association's House of Delegates. I'm former chief of staff at the University of Iowa Hospitals and Clinics and past president of the Faculty Senate at the University of Iowa. And I'm past president of the Iowa Medical Society and Johnson County Medical Society. I'm honored to be here today to share with you some of our thoughts on innovative models for chronic pain management and addiction treatment in the state of Iowa. I will be structuring my comments today with a specific focus on the Medicaid population. Medicaid members include the state's most vulnerable population, moms and babies, individuals with chronic disabilities, and low-income seniors, all of whom are vulnerable to opioid addiction. These individuals are often dealing with complex psychosocial and other health issues, along with issues around pain management and the use of opioids. Additionally, Medicaid members are more likely to have behavioral health and substance abuse disorders. As a result, the impact of the opioid crisis is magnified in the Medicaid population. My comments will be focused on 3 areas. The first will be proactive initiatives to prevent opioid misuse. The second will be treatment situation in Iowa, including some of the steps that AmeriHealth Caritas Iowa is taking, and the third will be recommendations to help prevent the advancement of treatment and reduce the risks in Iowa. So the first area will be proactive initiatives. Chronic pain is a multifactorial problem, and as such, AmeriHealth Caritas is taking a multifaceted approach to address it. At AmeriHealth Caritas, we have processes in place to identify at-risk members. For example, we're monitoring for overprescribing of opioid pain medications and reaching out to those providers to discuss the members' cases to address clinically appropriate utilization of the opioids. In other markets, we found that pharmacists' telephonic outreach has been helpful to providers to help deter overutilization, and we hope to encourage these actions in Iowa. Additionally, we have implemented a pharmacy lock-in program. This program restricts identified members to one pharmacy and to avoid situations where members may have been obtaining prescriptions from multiple providers and getting those prescriptions filled at different pharmacies. A multifaceted approach is taken, which also includes triggering care management for some of these members, as well as quality of care investigations when appropriate. We also have begun a provider education process. This process works to make sure that the providers are aware of non-opioid pain management treatments that are available to their patients, such as physical, occupational therapy, and chiropractic services. We also have begun a member education process. In our member newsletters, we have some prevention information for them as well. And then our current care coordination efforts include activities to address the opioid risk. Our holistic approach to integrated care management is a vital component of the work that we do to help our members manage their chronic pain. Our integrated process merges behavioral health support with their physical treatment for chronic pain as well as for addiction. Our members are screened, and then those identified with possible substance abuse disorders can be directed toward the appropriate interventions. And also because the opioid use during pregnancy can contribute to poor health outcomes for the mother and the baby, we currently track all prescriptions, narcotic prescriptions that are given to pregnant members, and all those members we outreach to them to make sure that we try to engage them in high-risk pregnancy care management. We also work closely with substance abuse treatment centers throughout the state to identify locations that are able to accommodate these pregnant members, including those which would allow the women to have their child accompany her for inpatient treatment. Unfortunately, there are few options in Iowa for pregnant moms to have their babies with them.
Repeat that again.
We've reached out to different treatment centers to try to figure out if they would allow pregnant moms to have their babies with them for treatment, and there are not many options available in Iowa currently. We also collaborate with the Department of Human Services, and we're working with our partners at DHS to adjust the pharmacy guidelines that align with the CDC opioid recommendations. Our second area was treatment options and challenges in Iowa. National figures on the opioid crisis have become staggering, and the rate of Iowa has not been immune to the loss of life from the epidemic. In fact, the rate of prescription opioid deaths in Iowa has quadrupled in the past 20 years. In Iowa, the limited access to effective treatment options has made it challenging for members to receive the help they need. One evidence-based intervention available to treat the opioid addiction is medication-assisted treatment. Medication-assisted treatment at a high level is the use of medication in combination with counseling and behavioral therapies for the treatment of substance use disorders. It is a valuable service during the immediate withdrawal process, as well as long-term abstinence of the opioid-addicted individual. Unfortunately, the lack of resources to prescription medication-assisted treatments has created barriers to successful outcomes for addicted members. For example, success rates for long-term abstinence from opioids are as low as 10%, without medication assistance, and as high as 70% with the use of the drugs such as buprenorphine and methadone maintenance. However, while AmeriHealth Caritas contracts with 100% of the available providers, Iowa only has around 50 providers across the state, mostly in urban areas, that provide these services, which is substantially fewer prescriptions or prescribers per capita than in most other states. Another medication that is an important tool with medication-assisted treatment is a drug called Vivitrol. And Medicaid members have access to this drug in oral form, but which has to be taken daily. There's also an injectable form, which is longer acting, which is preferred, especially with these members who have a poor history of compliance. But they still have to be motivated for recovery. For Medicaid, the only way a member can get access to this treatment is for a physician to administer the drug in their office. This is a costly method for physicians and therefore significantly limits the access for members.
How many physicians do you think can do that?
How many do that?
How many physicians are?
We know that with the some of the medication treatments, we know that there are, to go through certain treatment, there's only around 50 providers in the state.
Who can use the injection?
That can provide some of these services, that have gone through the treatment or they've gone through the education in order to do some of these treatments. Another important treatment is the use of the overdose reversal drug. The Iowa Board of Pharmacy and the Iowa Department of Public Health have created a program to make overdose reversal drug naloxone available to opioid users and other family members without a prescription. The medication is proven worldwide to reduce opioid overdose fatalities. However, Iowa Medicaid members are not able to participate for other members due to some regulatory restrictions. The other thing is the use of the prescription monitoring program. It's a statewide registry that opioid prescriptions by individuals regardless of where the individual got their drugs or who the payer is. Prescribers can log into the program to get their patient's opioid history prior to prescribing. However, registration and use in Iowa is not, it is not mandated for prescribers or dispensers. It's also widely not used by prescribers or providers because it is cumbersome and time-consuming. MCOs do not have access to the registry currently, and also pharmacies in Iowa currently have 7 days to upload the information, so there's a delay in getting that information in a timely manner. Last area is the recommendations. As this committee evaluates the opioid epidemic in Iowa and prepares final recommendations to Governor Reynolds and the General Assembly, we provide the following recommended strategies for your consideration. One area is to increase access. So we'd like to work with DHS to increase the drug the Vivitrol as part of the medication-assisted treatment by exploring other options for delivering this injectable drug. The second, encourage the Iowa Department of Public Health and Human Services to identify a way to allow Medicaid members to participate in the standing order program to ensure access to naloxone, the opioid overdose reversal drug. This may also require a discussion to promote funding for a more accessible use of this life-saving drug. The third area is continue a multifaceted approach, including providers, members and their families, advocates, law enforcement, and the Medicaid, the MCOs to identify and overcome Iowa-specific barriers and implement solutions to create a more accessible, efficient, and productive addiction treatment environment. And then we have a few recommendations related to increasing education. One, expand the available resources and education opportunities for prescribers, nurses, pharmacists, and other practitioners on evidence-based pain management treatment and opioid prescribing, as well as the identification of patients at high risk for opioid abuse and addiction. Second, work with the Department of Public Health to help develop public awareness campaigns. Third, require mandatory pain management education and trainings for all prescribers, including generalists and specialists. And then we'd like to expand the use of the prescription monitoring program by requiring use by prescribers and dispensers, requiring pharmacies to upload the information within 24 hours, allowing the Medicaid managed care organizations access, and encouraging further refinements in the tool that would include alerts on unusual member utilization. In closing, we recommend the committee, we commend the committee for recognizing the serious and growing challenge associated with this complex issue. MaryHealth Caritas Iowa will continue to collaborate with other agencies, community partners to address the interrelated challenges posed by misuse of prescribed opioids, heroin, and synthetic opioids such as fentanyl. In collaboration with IME, MaryHealth Caritas Iowa will continue to support the implementation of evidence-based strategies to improve opioid prescribing and pain management, reduce overdose deaths, and increase access to high opioid abuse treatment. Opioid addiction is a great equalizer. While many of my comments have been specific to the Medicaid members we serve, opioid has no favorite gender, race, age, or socioeconomic status. Everybody is at risk for falling victim to the opioid crisis. Thank you for the opportunity to share our thoughts with you today.
Any questions from the committee? I have one. So, let's say, for instance, the legislature would pass legislation that deals with a mandated approach to a mother who is pregnant at the time and is addicted. And we have a baby inside that probably is going to come out and have withdrawal issues. My question is this: will you resist that type of legislation because it hasn't necessarily been addressed in a per member per month negotiation on your contracts with Medicaid? I mean, what kind of flexibility do we have as a legislature to move forward with change that might increase the amount of investment that the managed care companies might have to make toward our opioid problem? Or are we going to have to come up with the money first and then pass the legislation? I mean, I'm asking as a legislator to a managed care company, how much cooperation can we expect if we come with change and it might adversely affect your numbers in the current year? You get what I mean?
I think that's a hard question. I mean, I know that we want to work well with you, and I think that, I think good communication all along the process is the best way to go about it. I mean, it's hard to say yes or no, in kind of a theoretical, question. We want to work with you, and we are here to, serve the, Iowans. So I think that good communication is going to be the key as we work towards solutions.
I mean, if we want to get more involved in Medicaid-assisted treatment for our Medicaid population, I mean, are the managed care companies open to us moving forward with more access to these services? Or are you individually going to address it company by company and your relationship with the MATS, the treatment centers, and your Medicaid clients? I get confused as we approach managed care and understand the flexibility and what we have as legislators to address this issue and move forward and maybe increase certain aspects of what we are currently doing. You get what I'm after?
I think so, but I think when you think about it, I think it has to be a dual-pronged approach, because I think you have influence as legislators over working with our providers and our partners around the state. I think from each of us, it's going to require us individually working with those providers, as well. I think it has to be on both sides. I think bringing to bear all you have and all we have together towards collaborating and really helping the providers across the state of Iowa understand that, we see the need. We want to support the work that we're doing. We want to improve and increase the services available to Iowans. I think it has to be on both sides.
See, for instance, from when Mr. Bailey talked to us about law enforcement, person who's in prison, basically going to come out of prison, most of them, will be Medicaid eligible. They don't have any assets. They're broke. Most of them are. And so they're eligible for Medicaid. They went in with a substance abuse problem. So how do we address the issue of providing supports as they move back to the community, that we can keep them away from, in the transition period from prison to community, and keep them away from potential addiction? Are you open to some type of program like that?
Well, I think one thing to keep in mind is that as an insurance company, making sure that members are getting adequately treated for their substance use disorders really behooves us, because we know that undertreated or untreated diagnosed substance use disorders lead to an increase in overall healthcare expenditure. There's a number out there that I saw recently where it's like 3 times as much in terms of overarching healthcare expenditure for someone who has a substance use disorder, whether it's opioid use disorder, alcohol use disorder, any of them. But making sure that we address those issues, and in this case scenario, someone coming out of prison, needing that wraparound support and ability to continue, and maybe some of the things that they started while they were in prison. These are all things that we're all going to have to take a look at and make sure that those types of services are available.
So I guess the big question I ask is, as you people negotiate your contracts with IME, and you have this per member per month number, that global number that each of you deal with, how much per client, and then when the client sign up with you, how the funding follows the client to your company. As you look at the opioid issue in our state, and you look at what you envision as you work toward more Medicaid-assisted treatment, this means more mental health issues that need to be addressed and paid for. Are you taking that all into consideration as you negotiate with the department on the new global number?
Well, I guess
how much flexibility you got in your numbers to address what we feel is coming and what is needed.
Right. Yeah, I think generally speaking, I can say that, of course, again, to reiterate, I'm here to represent Anthem, the parent company, from a national perspective. But certainly at the local level, we have two folks here from AmeriGroup. that have certainly, been digesting all of this, and will take this absolutely for consideration in any kind of contract negotiations, et cetera. But I just want to reiterate that the importance of making sure that people have access to a full continuity of care is really in all of our best interest. To make sure, whether it's from a legislative standpoint of view or from an health insurer point of view, if their substance use disorder is inadequately treated or undertreated, again, the unintended consequences of that are quite severe.
So when you, in your recommendation, say that you want to move providers utilizing the CDC alternative from 50% to 75%, how are you going to move them to 75%?
A lot of that is about education and helping them understand what the CDC guidelines are. I think there's still a lot of misunderstanding as to what those guidelines actually are, so educating our own providers that we contract with. I think the other piece of it is what I was talking about earlier, which is identifying who's using the opioids, who are our highest users across our state. Getting into their offices, talking with them, understanding what they're using it for, and then helping to re-educate them through that. Using our prior authorization program to actually do that. As they're writing prescriptions for, say, long-acting opioids that are going to require a prior authorization, it's an opportunity not just to go through a process, but it's to have a conversation, to take that opportunity to help them understand which direction to go in and what the other opportunities may be that they could choose.
So on that prior authorization, I also heard something about some insurance companies or legislators have worked it out with insurance companies or something, that when you have a partial prescription, in other words, the way it works is the doc prescribes for 30 days. But he also says that you are entitled to 10 days or 7 or whatever, a partial prescription. And then if you need more, you can ask for the remainder of the prescription. You know what I mean? Some companies, insurance companies, will say, we'll pay the copay on the first partial, but if you come back for the rest, you'll pay it all yourself. In other words, it discourages people from getting the full prescription. It encourages them to take it up front and then leave the rest.
Right, I have heard that. But one thing about Medicaid is we can't charge any of our members. Our members don't pay any money.
Even in expanded Medicaid?
No, they
I
don't.
don't think so.
No, we're not able to. We're not able to balance bill
private
them.
insurance companies, but still the Medicaid rules apply to the.
Correct. We
private.
can't balance bill anybody for Medicaid.
Okay, that's a commercial insurance issue.
Yeah.
Okay. That's it for me. Jeff?
Thank you, Representative Heaton. You asked some good questions there. I'm going to try to come back to one of them from a different direction, but I guess at the outset, I'm pleased that all 3 MCOs were able to be with us today with some really key personnel, relevant to this issue. Sometimes we have trouble getting to the right people through your legislative liaisons. And so hopefully we can follow up directly on things that may be of unique interest in our districts. If you read the headlines in the newspaper in Dubuque over the last couple of years, you'd think that violent crime and gangs are our biggest law enforcement issues, but when you talk to police and sheriff personally directly, mental health, people with substance use disorders in the system. And you listen to the national webinars that involve law enforcement, and they say, what's the single biggest issue that we can help them address as part of that complex? It's housing, which is basically, housing other than the jail. And I think you'd see a lot of prosecutors willing to work with diversion programs if there were places for people to go for detox, long-term treatment, transition back into the community, etc. And so Melissa Springer was here a little earlier from Mercy, is talking in Dubuque, we'll be a little parochial here, about working with the community for the upfront capital investment required in creating that type of facility. But the big question then becomes staffing it with professionals, and then how do you pay for the services that, you know, accrue to the folks who go there for a week, 30 days, 60 days, whatever. I don't know which of your organizations have the biggest footprint in Dubuque, but I guess the question is, are you willing to sit down with communities that want to develop tailored responses to this issue and maybe work out, call it a pilot program, within the scope of your current agreements? Because like executive branches, people may have observed, isn't particularly interested in having legislators intervene in their relationship with you, its relationship with you. But within your current contracts, can you work with communities on those type of projects?
Yes, we can, and we would love to. So yes, we very much want to work with communities, providers, members. We are here, so we are, yes, we're, you know, invite us wherever, and we're happy to go. We're always happy to listen and try to work together.
Yeah, I would second that. Yeah, absolutely, we're willing to have those conversations.
You can make it free.
I'll have Melissa put you on the distribution list for the opioid response team meetings. Second quick question for the cardiologist. I've heard some rather dramatic stories about the relationship between opioid use disorder and heart disease that may not be immediately recognized as an opioid addiction problem. Can you address a couple of those and the series or significance of that?
Sure. I mean, sort of ironic, it was the research that I did in medical school, is that we know that opioids themselves actually have cardiovascular effects. If you're looking, for example, at somebody's EKG, you can sort of dissect different parts of that heart rhythm, and they represent different processes within how that heart function is happening. Because it's all at the end of the day really about plumbing and electricity. You have to have both of them in order for them to work. Opioids themselves can actually have an impact on how, it's called repolarization. So the heart sends off a signal, it tells it to contract, and then it relaxes and sort of recharges itself. During that period of time, the heart can be very susceptible to bad heart rhythms. Several of the opioids, for example, morphine, fentanyl, methadone as well, can change somebody's EKG characteristics, and some people are more susceptible to that than other people. Women can sometimes be a little bit more susceptible. There are people who by their very nature have a different conduction system, so just by that it can have some more profound effects. But then you take into consideration people who are living with chronic heart disease. They are already, by virtue of that, very often a little bit more medically fragile and more susceptible to complications related to opioid misuse.
Quick follow-up. Our Mercy Health Center is the heart hospital in Dubuque, and they said there had been an increase in a certain type of invasive surgeries required due to a specific condition associated with opioids. Forget the name of it. But they've been seeing an uptick in that that's very expensive, I guess. And so there, I guess my point is there are things out there that we don't necessarily count as a cost related to opioid addiction.
Yeah, I mean, the cost of opioid addiction goes so far beyond what we see here. I mean, it's hard to measure the societal impact of these drugs, as well as sort of those unintended consequences of how they affect the human body in different ways. And so I completely agree. I didn't think I'd get something like that.
I just want to get into this. I mentioned ACT before you guys came here, I think, this morning. This morning I mentioned ACT. And we're having I visited with a psychiatrist from the University of Iowa who's kind of a real advocate for spreading ACT across the state. And she's in charge of the ACT program in Johnson County. And I've met with Lynn County ACT people and also the other ACT in Lynn County. There are two. The issue is that we are having difficulty in spreading this across the state because of the reimbursement rate that other communities feel they need in order to do an ACT program. ACT program is supporting chronically mentally ill, which a lot of our opioid people also have. And so it keeps them from going to acute level care, which is $1,100, $1,200 a day. And so we can work with them in the community, stabilize them, and they're able to live in the community. But the rate that they need is $40 more a day than what you're paying currently. And she told me that she has 10 communities in this state ready to sign on with ACT if they could just get an increased reimbursement. Now, I feel we're turning our back on a very progressive approach to mental health, and it could also involve substance abuse also. I just wanted to, you're here today, we're in the middle of it all, and I just thought I'd push along what I've heard, and I would certainly like to see some type of positive response, because I think we're missing the boat. We've only got, Broadlands wants to get into it in Des Moines. They won't go yet. Davenport signed on this 2 weeks ago, and they're going to have an open house the 1st of November. How they can live with the rate that they're getting paid, I don't know what they're getting paid. Sometimes you're up to individual negotiations, guys, and so we really don't know. But I'm just saying there's a concept out there that's evidence-based, progressive, can solve our problems a lot with the need for acute level care beds, along with our crisis intervention, and if we can finally get some type of agreement on paying the Medicaid services that are occurring in our crisis intervention centers, which have yet to be had. The counties are now picking up all of the bill, and they're being threatened to close, and Centerville closed. But anyway, we're on the edge of some very progressive things, and I'm waiting for managed care to grab it and carry the ball. Because when you first came here and sold us on the idea of managed care, this was your mantra. We can be progressive and make this system better and more efficient. And I'm waiting. It seems as if we're still looking at things the same way that we had in the past. And I'm looking for change. Thank you. Yes, Ken.
One quick question on the 7 days for short-acting opioids, you said. Let's say the physician wrote for 60 tablets twice a day, 30-day supply. We're only going to fill 7-day supply. Would that accrue one copay for the patient and one dispensing fee for the pharmacy? And what if they need more on the next fill? Would the pharmacy be provided with another dispensing fee?
Well, the first thing I'll mention is that doesn't apply in Iowa, at least with our pharmacy point of sale edit, because I believe that there's a regulatory, we're not able to have that. That's the limit to the 7-day supply for first fill opioids. But to answer your question for other markets, I'll certainly take that question back and get back to you and let you know what I find out in terms of how the mechanics of that work.
Okay. Thank you.
Thank you very much.
Thanks.
Very, very interesting, and I appreciate your passion and your ideas, and we look forward to seeing it move forward on this issue, and thank you for coming today.
Thank you so much.
Our next guest is Mr. Matt Bovard, the Iowa Physical Therapy Association. And he's going to talk about alternative pain treatments. And on a lot of pharmaceuticals, now we're looking for alternatives. So, would Mr. Bovard approach the table, please?
Good afternoon. Thank you for the opportunity to address this committee. I do represent the Iowa Physical Therapy Association today, and I want to just highlight some of the efforts that are being made in the state and nationally to address the opioid epidemic through physical therapy alternative treatment methods. In 2016, when the CDC came out with the guidelines for recommending safer alternatives for management of pain, the American Physical Therapy Association acted on that quickly and launched a campaign called the Choose PT campaign to educate the public in methods that physical therapy has at their disposal to address patients' issues with chronic pain or acute pain to prevent it from becoming chronic as well. This effort was launched with a national media campaign, online advertising, TV, radio, public service announcements, targeted advertising, and media outreach. These efforts continued at the state as well as the national level concurrently. In the fall of 2016, the Iowa Physical Therapy Association was awarded a grant from the American Physical Therapy Association and launched this campaign within the state. There were numerous billboards that were placed around the city to highlight the efforts and just help, again, raise public awareness that physical therapy is an alternative to pain management as opposed to opioids. The American Physical Therapy Association continues to make space available on their website. The moveforwardpt.com website offers resources for physical therapists as well as information for patients regarding education about pain, alternative methods of managing pain, tips for avoiding chronic pain, all those types of, all those pieces of information. With the ongoing effort in trying to educate the public, I do want to highlight just a personal story of a patient that I've had in my treatment for some time now, who has a history of dealing with opioid addiction. This is a gentleman who was addicted to opioid pain medications for more than 20 years. And the thing that I always highlight when I tell this story and when he's told this story publicly with me is that his intention was never to become an addict, but his intention was to be able to continue to run his business, to support his wife and his 3 children. And opioids at the time seemed to be the only method for him to manage his pain. Fast forward 20 plus years when he presents in my clinic, 2 weeks post getting off of his opioid pain medication, which he describes as 2 weeks of hell. He said he can describe it no other way. We were able to start working with this patient and provide him alternative means for self-management, education, through exercise, through flexibility training, through movement awareness training. He's able to start making progress. He told me later that he really didn't plan on coming back to his second physical therapy appointment after his first visit because he felt that he tried it before and he didn't think it had anything to offer. But something made him did come back, and he's continued working with himself and progressing himself with his own self-management, and has been able to be off of opioid medications for quite some time now. The most touching story and the most heartbreaking story at the same time that he's told me is when he started to actually feel better and be able to function more in his life, he went out to play a game of golf with his 3 boys, who at the time ranged between 16 and 24 years old. And they commented as they're out enjoying an afternoon of golf and just, you know, enjoying each other, joking around, having fun. They said, "Gee, Dad, you're actually a lot of fun." And he said it hit him at that moment that none of his boys knew him as a non-addict until then. He had always been addicted to opioid pain medications from the time his oldest was very, very young. And the fact that his sons would recognize that he was a different person when he was able to manage this without opioid medications He said it just about took him to his knees, and he still gets a little choked up talking about it when we visit about that day. So in his mind, I think the message has hit home that the physical therapy can offer a very real alternative for prescription medications in addressing pain. He said he wished he would have given it more of a try many years ago when his pain was still acute, before it had a chance to become chronic, because of the obvious reasons of the side effects aren't there. We're very nice people as physical therapists, but as far as we know, we're not addictive. So he said he wished he would have been able to take advantage of that in a different way years ago. The sad thing is, too, with his story is that he had tried multiple times over his 20-year history of addiction to seek help in getting off of those medications, and he was unable to find adequate help with that. The other sad thing is, he said at the time it was far too easy to continue to get opioid medications. He did a lot of doctor hopping, and when he could no longer find doctors to fill prescriptions, he was actually able to find a resource online which gave him an interview on the phone, and 3 days later he had 240 hydrocodone in his mailbox. So this is a frightening thing. That company no longer exists, thank goodness, but it certainly did at the time, and that certainly added to his addiction at the time. So I would just like to again reiterate that physical therapy does have evidence-based, high-quality, recognized means by which to treat pain.
So I have a question. Now, you know, your client, your patient was dependent. I mean, not addicted, he was dependent. We got that straightened out, and I'm glad we did. So, did he have insurance?
I can't speak for his entire history because he did not live in the state during part of the time when he was using regular prescription opioids. And I've only known him for a short period of time, but in the time I've known him, yes, he has insurance. He's insured through one of the MCOs in the state. So
I guess, now when I had my knee surgery, they gave me 8 weeks of therapy. That's what I was eligible for. And when those 8 weeks were up, goodbye. So what is it like when you're dealing with chronic pain? Was there a limitation on the number of weeks that you had available to you that would be paid for by insurance? Or did you have an open end?
No, there's limitations, and you know, certainly in his case, you know, when you're dealing with a 20-plus year history of not only chronic pain, but then also coming off the opioids, oftentimes the limitations are difficult to deal with. There are means by which we can ask for extensions, and we have varying degrees of success with that as far as being able to seek extensions for our patients.
Well, I mean, did the insurance company continue to pay as long as you felt the patient needed treatment? Or were there limitations that they placed?
In his case, we have had success in continuing treatment, although there have been times when his coverage, he ended up paying out of pocket for himself, yes. Because he felt that it was enough of a value that he didn't want to backslide. He said there's just no way he could go back to being on pills.
I'm just bringing up the fact that sometimes there is a built-in prejudice, I guess I could say, on alternative methods of treatment. I mean, we look at our medication-assisted treatment, and sometimes that's accepted more readily than the alternatives. And I just wanted to know what your reception was as being a physical therapist with a third-party payer.
In general, we are received as a reasonable alternative. Again, the continuation of treatment sometimes is a challenge, and there are barriers placed in the way with the issues of chronic pain.
I wanted to start a legislative fight, I would raise this as a scope of practice issue, and that fight would take place in this room. The State Government Committee. I guess my question is kind of a general one. When you look at what physical therapists do specifically and pain treatment in general, is there a difference between PTs who are working as part of a medical group versus PTs who are kind of, I would say, independent of medical groups?
So you're referring to people who may work for a hospital organization versus a private practice situation?
Well, sometimes when you think of alternative treatment, you think alternative to what a doctor might want or be naturally inclined to do, you know, based on their experience and education. So I guess when we look at alternatives in your experience, what relationships is there with your association, for example, and say the medical society, and working together to make some broader changes in practice, actual practice, without necessarily saying go to a physical therapist for a treatment versus go to a doctor?
Well, I think in general our organizations, the medical organization and the physical therapy organizations work well together. I don't, my personal opinion is I don't see it as an either or. I feel like we all have to be on the same team and we all have to be working toward common goals with patients. I don't feel, when we say the term alternative treatment, it's alternative to a prescription medication, but I don't feel it's alternative to the entire medical model. We do look at being evidence-based and in our approach, but evidence-based needs to be a combination of research. It needs to be a combination of the clinician's personal experience in practice, and also taking into account the patient's goals, beliefs, attitudes, all those things. There has to be a group effort on that in that direction.
Thank you very much. Appreciate your presentation.
Thank you for your time.
Thank you.
Our last guest this afternoon before public comment will be Dr. Wes Nyberg of the Iowa Chiropractic Society, and he too will address us on alternative treatment. I'd also acknowledge Executive Director, Mr. Fitzgerald.
Yeah. Thanks, Matt. Can you guys hear me okay with this? I want to make sure I'm close enough for everybody. So, first off, thanks for the opportunity to sit down in front of you. I think maybe a month or so ago we didn't have this opportunity, but we had some legislative socials and we were able to get in front because I think some of the representatives, at least that I met with at our social, were surprised that chiropractic had a stance on this situation, and that's what I hope to show today is a different approach. So we're here today with Matt Fitzgerald, as most of you maybe know, who's our lobbyist for the Iowa Chiropractic Society, and then Kayla Schmitz is our key staffer with the ICS. Dr. Loren is here representing the Iowa Chiropractic Society, and this year I'm the president of the Iowa Chiropractic Society. I'm a graduate of Palmer College of Chiropractic right down the road in Davenport in 2005, and I've been in solo practice since 2007. So what I think we want to share today is, you guys have heard a lot of stats. We I think can all agree that opioids, the prescriptions are going up, and that this is a problem. And there's many levels that I think we would all agree that this needs to be addressed and looked at. My hope today, though, is I'm going to show you, I think that chiropractic can offer maybe something completely different that maybe hasn't been approached today. And of course, we'll have time for questions at the end. A few months ago, politics aside, President Trump did come out and say that this opioid situation is an epidemic, and I think that's something that we can all get behind. We've been very active as the ICS, taking a hold of this, and last month you have the briefing there. One of the handouts is we were able to work with Governor Reynolds, and she was able to sign a proclamation declaring September was Drug-Free Pain Awareness Month and recognizing chiropractic as a very good solution to this. We also have a handout in there from the Attorney General urging the states to look at non-prescription uses, obviously, for this problem. I think we're doing that. We found an interesting stat here I do want to point out. From 1999 to 2014, there's more than 165,000 people that died from opioid problems. And that's 3 times the number of military deaths during the Vietnam War. So this is a big problem. But the chiropractors, we are working, and we're working hard, and we're doing some different things. On the next page, you guys see is opioid deaths in Iowa specifically have also increased, and that's why we're all here today. So I'd really like to zero in on what's unique, and there's a slide in there that looks at the total hours of education that a medical doctor, a DO, and then a doctor of chiropractic. And you may or may not know, but at a national and also at a state level, chiropractors, especially in Iowa, we're considered primary care physicians, just like an MD, just like a DO. We do the same neurology classes and spinal anatomy and biology and chemistry and physics and everything. The key difference, though, if you want to say, comes down to the treatment or the application of how we help our patients. Medical doctors, DOs, they're going to do prescriptions and medications and possible surgeries if that's their specialty. The doctor of chiropractic is, we do not deal with medications. We cannot prescribe, nor will we ever prescribe medications. But what we do have is what's called the adjustment. And chiropractors are trained to address neuromusculoskeletal conditions. And the majority of people that get hooked on prescription opioids come from a neuromusculoskeletal situation. Low back, they throw their back pain out, they throw the back out, their shoulder pain, something like that. The majority of these people have a neuromusculoskeletal situation, and that's exactly what we're designed and trained, very well trained, to handle and to help with. Just a couple quick stories. I had a patient many years ago. He was in bedridden for 2 or 3 weeks. He couldn't work. He couldn't get out of bed because of his back. It was so bad. And he was he used to work for, he works for Quest, and he was laying pipe, telephone lines. And his wife was able to get him into me, and after a few weeks, we were able to get him up. He was off the medications, and most importantly, though, is he got his life back, because he was thinking he might have to go back on disability and have short-term or retire early. And we were able to, he didn't have to do that, and he still works there today, and he's going to retire soon with full benefits, which is great. I had another patient a couple years ago named Barry. He was a military vet, and I know that's a completely different situation, but he was had some prescriptions and kept throwing his back out and never found any relief. And after seeing the chiropractor myself, we were able to get him off those medications, and he's doing much better, getting back to work, and he's doing fantastic. And I think that's the big difference here with, you've heard lots of things, and this opioid situation is such a spectrum. If somebody's hooked on, how do we help them get off? But I think the thing that we're missing is that chiropractic can step in almost at the beginning, at the door, and at the doorstep, and we can help prevent these people from ever needing the medication to begin with. And I think that's the key thing that maybe that you guys can take away. And what's great with chiropractic is that there's so many different techniques. So just because I use a handful of techniques, that may not work for you or for somebody else. But what's great is that there's another technique down the road, and that probably will help somebody. And so that allows us then that we can help more and more people because of all the different approaches through chiropractic. So it's about finding the right chiropractor for you. I always like to use the analogy, if you didn't like your dentist, you're not going to stop going to the dentist. You're going to find another one. So a lot of the drug addictions, they begin with opioids, but like I said, is the majority of these come from an injury. They throw their back out, they have neck issues, they have some type of pain, and they're looking for relief. And I think chiropractic can help. Now what's very important is that chiropractic is very safe. There was a huge study done up at Palmer College of Chiropractic, and they looked at, side effects. And we have to look at those adverse reactions. For every medication, there's a side effect. For every treatment, there's a potential side effect. And there's a great stat in there that with the chiropractic adjustment, it's less than 1 per 1 million where there's some type of very serious outcome. So it's very, very safe, and most importantly too, it's cost effective. We didn't bore you with all the statistics. If you want, I'll be happy to provide them with you. But there is so much research out there that shows that their first entry point for chiropractic, it saves money, less hospitalizations, less MRIs, less surgeries, less opioids, all of those situations when their point of entry is with chiropractic. And the satisfaction is very, very high too. I think behind maybe it's a massage therapist, but chiropractic is very, very high patient satisfaction, which they like what we do, and that's why they continue to come back. So the DCs, like I said, we're recognized as primary care physicians, which means we can help. We do not prescribe medications. We cannot take somebody off a medication. However, we can work, and we do work with doctors, and we need to say, hey, we've got something, that's getting better. Can we coordinate with you to get them off of those medications? So we do need that coordination. But chiropractic is drug-free, it's non-invasive, and it's definitely cost-effective, and use has definitely gone up. And you guys have heard a lot of information, a lot of stats and ideas, and how do we approach this? It's an epidemic, though, that affects all of us. It's my patients, it's our patients, it's your constituents, it's friends, it's family. They're all being affected. The situation needs to be addressed. But it's about safety and doing what's right. And chiropractic was discovered in Iowa in 1895. And Iowa, I think, can be the leader for attacking this epidemic by not only treating and helping those addicted, but I think we can help them prevent people from getting on the medications to begin with. The ICS has been very active since this situation. We've formed new committees for public awareness. We're working with our national company, the Foundation for Chiropractic Progress, which is all about positive press releases. And that's where a lot of the information came from today. And then we were able to find the local information as well. But we're trying to get that information out there. It's a new committee, but we're working hard. We need to make sure too, though, that access to chiropractic is not restricted. And if you have more questions about that, I'll be happy to answer. But chiropractors, we have a serving heart. We've been helping, we're here to help, and we're also ready, willing, and able to do what's needed so we can help this situation. So thank you for your time, and I'll be here to answer any questions that you have.
So I just want to check and ask you your relationship with our managed care organizations. Is it a good relationship?
You have specific questions about that?
What?
Just my relationship in general?
Does your industry have a good relationship with the MCOs in the treatment of pain?
Average. We have to watch it very closely. There's been points where they're trying to, and they have been trying to restrict access to chiropractic. Looking into options like pre-authorizations, where somebody would need a medical doctor's referral to come to the chiropractor. Reduction in maybe say the number of visits by, and also reduction in overall pay. And those are trends that we've seen. They haven't fully implemented the referral yet, but I think there's been conversations, and I know our lobbyists and the ICS is very actively engaged to make sure that doesn't happen, because from our perspective, it just leads to higher costs all across the board, and it can delay when a patient could get care.
Well, I appreciate your candid response. I just wanted to check, make sure that, understand exactly how it's going out there. It sounds to me a little bumpy.
It always is. I mean, it's a new program for sure, but I know that we're watching it. We do have conversations with them. We're trying to stress, but I think that's one thing that all of us are here in ICS is we want to help. We want to be a resource for this committee, for legislation to help. We want to work with the MCOs. We want to work with the medical doctors and the PTs, but we want to be here. We want to be here to help.
Any other questions for the good doctor? Thank you very much.
Thanks for your time.
Okay, we come now to public comment. Do we have anyone who would like to make public comment at this time? Please sit down, press the microphone open, and wait a minute, what am I doing? Public comment. Well, yeah, I have the health department.
I'm publicly speaking.
You're making a public comment?
Yeah.
Okay, I'm sorry.
I know, it's confusing. I
I
get it.
automatically just associate you with a...
Well, good, that you're supposed to. Thank you.
Okay, so
I'm doing my job.
I guess we're going to listen to Dr. Janice Hendricks of the Polk Medical Society. Is that you?
That's me.
All right.
I am Dr. Janie Hendricks. I'm an internal medicine doc, past president of Polk County Medical Society, and I'm representing the doctors of Polk County who see patients in central Iowa and also patients in rural Iowa. And I'm here today as an advocate for our patients. We had some concerns with recent developments on the opioid crisis. And there seems to be kind of a one-size-fits-all approach from the insurance companies for treatment of this opioid problem and limitation of the medication. And so we're concerned with this one-size-fits-all approach to pain management. I'm a physician, had 5 years of college, 4 years of medical school, 3 years of residency. A lot of physicians have a fellowship after that. And that's what we're trained to do, is take care of patients. And that's what we want to do. I don't want to addict my patients to opioids, but like it or not, that is one of the things in my arsenal to treat pain. And to limit patients to a 5 to 10 day supply and then require them to come back to see me to get another prescription. A Schedule II narcotic, you have to have a written prescription and you have to get it from your doctor. If I send them to the pharmacy and I write it for 50 pills and the pharmacy says you can only have 30, they can't get those 10 pills later. They have to come back to me and get a new prescription to be filled. Now, what this prior authorization that some of the insurance companies is doing will allow them a 5 to 10 day supply, and then they have to get a prior authorization to get more. The prior authorization may require them to have a urine drug screen, to sign a pain contract, and send that in with the insurance to the insurance company, along with answering multiple questions such as, have we tried alternative means? One example I'll give is one of our ortho docs does knee replacements. You may do a knee replacement 1 week and they come back in a week or two for their second knee replacement. Obviously, most patients after a knee replacement need opioid narcotics to treat the pain. They may not get that second prescription because it's within 30 days and it can't get filled without a prior authorization. Take 48 hours minimum to get the prior authorization. Meanwhile, he may not have his pain medication. The other thing with the prior authorization is it takes the physician's time, the staff's time. Overall is going to increase the cost to the patient and to all of us. I just don't think that's the one-size-fits-all way to go. I'm all for other pain management techniques for long-term pain and for people who need them. But I think this isn't the way to restrict to treat this opioid crisis that we have. I don't think this is helpful. I think I know better how to prescribe medicines for my patient than the insurance company does. The other thing I wanted to cover, one of our docs is a radiation oncologist, so he takes care of cancer patients. A lot of rural Iowa patients, 70, 80-year-old patients, they get chronic pain medicines in order to survive. It's a quality of life issue. For them to have to come back to Des Moines, Iowa to get their prescription is a big problem for them. Also, are you going to ask your 80-year-old father to fill out a form that says he's, that he doesn't smoke marijuana, he's, not going to see other doctors, and give you a urine drug screen before he can get his first prescription? He has a relationship with his oncologist, and his oncologist is going to make sure he's not over-treating his pain, but he's going to, make sure he's comfortable and has a good quality of life. And I don't think we want to override that with the other rules and regulations. So I think that was, pretty much what I had to say. I think we don't want our patients to suffer. And, the PMP has been wonderful. I can look up and see what, if my patient's been somewhere else to get other pain medicines, and I would agree with having that updated sooner. But I think there's other ways to go, and you've got a lot of good ideas from people today. Any questions?
What do you think of the idea that all opioid prescriptions, level, what do we call them?
Schedule 2.
Schedule 2, have to be filed electronically. No more handwritten prescriptions.
Right now, we can't do Schedule 2 prescriptions electronically. You have to handwrite them.
But that doesn't provide necessarily accurate data. When you file electronically, they are into the computer and they're there. And it's readily accessible on the PMP.
Right. And I think with proper controls, filing them electronically is great, especially if we get more accurate PMP input and get that information in there right away. If there would be a way to file that, send it to the pharmacy, and have it go through the PMP, that would be great.
So what do you think if you were employed by Unity Point on their staff? They own a lot of doctors here in Des Moines. And they came forward and said, we will now use the CDC recommendations, which means you will go to the counter first before you can get to the opioid.
You go to what first?
Over the counter. You will consider over the counter first before the use of opioids.
If a patient comes to me in pain and I think an over-the-counter medication would work for him, I will recommend that first. If I just did a knee replacement, which obviously I don't do, if I just did a knee replacement, I'm going to give him opioid narcotic medication to treat his pain. If the over-the-counter medicines work for that, and believe it or not, occasionally after a knee replacement, people don't need a lot of narcotic, it's rare, then I'm all for over-the-counter medication, but that narcotic needs to be available if he needs it.
Okay. Any other questions for the doctor? Yes, Senator.
As a pharmacist practicing for 43 years, I appreciate your comments a lot.
I have a pharmacy degree from Drake.
There we go, right? There we go.
I practiced a few years and then went to medical school,
There we go.
so I love pharmacists.
Good, thank you very much. I appreciate your expertise and what you do for your patients. I've always tried to look at things pretty straightforward and say that, I am a pharmacist, but I'm a patient advocate first.
Absolutely.
And we have to do what is best for that patient. You can determine if it's real pain just by looking at their face. You can tell if they're hurting. And over your past history as a physician, a knee surgery is going to require so much, or a scope or whatever is required for that patient. So we have to make sure that we take what is in the best interest of the patient first.
Absolutely.
And like I said, I appreciate you. Thank you, Doctor.
Any other questions? Yes.
One question, Doctor. Thank you for coming. Earlier testimony, you probably weren't here for it, discussed that many folks who develop opioid and heroin dependencies and addictions started out taking opioids in response to an acute condition that might have been a surgery, for example, but continued use of the opioid after the pain indications themselves were taken care of. What role does the doctor who originally prescribed the opioids have in long-term monitoring of the patient and assisting in ensuring, if possible, that a dependency and addiction does not develop after the initial acute condition is addressed?
I think that's the role of their primary care doctor. They have a relationship with that patient. So if I send a patient for a knee replacement and they're on their narcotic pain medicine, and say 2 months later they're still wanting narcotics, their knee doctor's not giving it to them anymore, and they come to me, I want to know why there's an exception in this patient. Why are you still having pain? Do we need alternate treatments? Acupuncture, physical therapy? Does he need more therapy? Do they need to take over-the-counter medications for that pain? Or is there something wrong with that knee that needs to be reevaluated? So I think that's the primary care doctor needs to look into that and not just keep refilling those medications. They need to see, what's the cause and what other treatments can we use.
I guess I'm thinking more of situations where the pain has been alleviated, but a dependency has or may have developed. How do we protect against that situation?
I don't know if I have an answer for that. I think if they're seeing they're getting that narcotics somewhere. If they're getting it off the street, I may or may not realize they have that. I think there are treatments to help with that. Cognitive behavioral therapy has been proven to help with people who perceive they still have pain or like the feel of that medication. So I don't know if I have a good answer for that, but in my patients I try to follow and make sure that I'm not still getting them the narcotics or they're not getting them from someone else, and if they are showing behaviors, would refer them for further evaluation.
Any other questions for the doctor? Well, thank you very much for
Thank
coming
you.
forward. Thank you. Deborah Thompson.
Hi.
Nice to see you.
Good to see you too.
Looking forward to hearing what you have to say.
Okay, thank you. I wanted to start by thanking you all for your leadership on this, in particular Representative Heaton and Representative Eisenhart. But the fact that you're all here today is really important. Today would have been my 7th wedding anniversary. And so I felt compelled to speak to you all about this issue because I have a unique perspective on it. My husband, Joe Thompson, passed away from an accidental heroin overdose last September. He left me and his 1-year-old son, Lincoln. I am the legislative liaison for the Iowa Department of Public Health, and while Joe and I were in the throes of what would become his final addiction cycle, I was simultaneously working on the Narcan and naloxone legislation. I always think of that as pretty ironic. I've been a part of or listened to much of the opioid-related policy discussions occurring at the Capitol, and I've spent a lot of time reflecting on how Joe would have or could have been impacted by these ideas. There's a lot of good ideas. I've also been reflecting on some of the rhetoric from policymakers in other states. Much of it is rife with stereotypes, assumptions, and lack of understanding or compassion. And that's scary to me, and I hope that Iowa's legislators will not follow suit. I know that those of you who are here today will not. I'm not always so sure about some of your colleagues, so just in case you don't have your own personal anecdote to tell them, I'd like to offer you Joe's. Joe was educated at Grandview University for nursing. He came from a strong Iowa family, many, many generations. He had a very good childhood. He made it to state wrestling twice, very successful in high school. He actually went to every single wrestling practice in all 4 years at Indianola, which earned him an Ironman award that we still have. He had very, very loving parents, healthy parents who were extremely supportive, even through the final days, and they continue to help me raise Lincoln now. We had a very strong marriage, a very stable state income, and were overjoyed when Lincoln was born. Joe was overprescribed after a serious car accident in 2004 by a doctor who wanted to treat his pain with a fire hose instead of a garden hose. That was his exact quote. And that started us on our nearly 13-year journey through this disease that he ultimately succumbed to. He was close with his doctor. I know his doctor from his childhood didn't intend for Joe's addiction to start in his office. I think to Mark Bowden's point earlier, they do have close relationships, and Joe probably did manipulate at times once the disease took hold. At the end, because of our own struggles with stigma, it's not just people outside looking in with stigma, the people who are suffering from it also have it too. We made a decision together to wean Joe off the Suboxone that had kept him alive for 2.5 years through treatment at UCS here in Des Moines. We heard from them earlier. We were talked into care at a reputable place in Des Moines because they have a good reputation and they promoted abstinence from all substances. Maybe they're very good with alcohol addiction, but they are not good with opioid addiction. They would not admit him until he detoxed from his medication-assisted therapy, the Suboxone, because they equated it with being on heroin. They felt it was the same thing. And so while trying to get him into this treatment facility, he became sicker, and then finally we found him. So I would at least implore you to listen to what Mr. Polich said about education to our providers. The place he went to was not USC, but the place he went to, which was not UCS, is not ready for opioids, but they're accepting patients anyway. All of the days of Joe's life, even the worst ones, were worth living. Those of your colleagues who were skeptical about the use of naloxone should know it did save Joe's life twice. And although he ultimately did pass, which is often a criticism of naloxone that I hear, he was able to see his son walk for the first time, talk for the first time, and he attended Lincoln's first birthday party where he saw many of his friends and family for the last time. It was a great day. People loved Joe, even when he didn't love himself. He was kind. He was part of his community in Indianola and also part of his recovery community. Every time he heard someone in his recovery community had died, he traveled to those funerals with friends of his from UCS so that people would know that their loved one was still loved, even if they had lost connection through the addiction. 300 people showed up to Joe's funeral, 300 people. He was very loved. I'm sharing this with you all because I want you to ask some questions. I've always been a resource to you guys since I was in the legislative branch, and I don't want you to avoid talking to me because now you know this. I want you to ask questions about how it works, and I'm around the Capitol all the time. I owe it to Joe to tell his story and to help people understand how to help. It's a very hard disease. It's very complex, as you all know, but living in it, it's really hard. I know it's a disease because I know Joe would have never chosen to leave Lincoln and I. He loved the life he had with us. It's a disease, it's not a choice. I'm proud of the work of my colleagues at IDPH, and I believe that we can head this off using good public health prevention strategies. You'll hear more from us tomorrow. Please continue to support our efforts and to be a leader on this issue as we try to be a leader on the issue as well at IDPH. Thank you for your time.
So, from 2004, when he had the accident,
yeah,
until this last year, 2016.
Right.
Joe was sick.
Joe was sick.
So, how was he able to obtain his drugs to satisfy his addiction? How was he able to do that?
Sure, that's a good question. So at first it was doctor shopping. He also was employed at UPS and benefited from the pill mills that were unregulated in Florida. So he had figured out which packages had drugs in them and had figured out how to get them out of UPS. And luckily, he was never caught doing that because that would have been an awful legal battle. He was never caught doing any of this. He does not have a police record. And then you meet people, right? He was in treatment several times. This was not an everyday thing. It wasn't an every month thing. It wasn't an every year thing. That's why they call it a cycle of addiction. So sometimes he would meet people at treatment, I'll be quite honest. Then there was just, networking. There were times he went to nursing homes to find it. Simmer on that one. Nursing homes, grandma and grandpa. Places in probably the stereotypical parts of town too. He was very honest with me. We had a good relationship. I wanted to help him get better, but those were some of his methods.
So he'd move into treatment and then fall off back and forth. Is that the way it kind of works?
Yeah, the first time he quit cold turkey. And then the second time, when we realized what was going on, he had already checked himself into UCS. It was
when you say UCS,
the United Community Services, the place where you went.
Yeah, where Mike
yeah,
was
this
here
guy.
earlier.
Yeah, Mike, right. Yep, so he had Dr. Filippelli. And that worked very, very well for 2.5 years. We were trying to transition him into, MAT is so new that it was the weirdest decision to have to make, because as we were trying to get him into PAL here in Des Moines, I was at an MAT training with Kevin and listening to the statistics. And so I kept calling PAL and I said, how are you going to deal with his dopamine levels? Well, not what are dopamine levels, but they just didn't have an answer for it. But Joe really just wanted to be done with all of it. He hated, because again, stigma. He himself struggled to think of this as a disease. He knew he had a disease, but in dealing with it, you have to go to a nice enough place, but not a nice place, on a regular basis, and you can't help but feel you don't belong there. And so he wanted to be done with all of it and thought he could, and the answer is he had a disease and he couldn't. And so we were trying to we abandoned PAL when we felt like they were jerking us around, and then we went to Mercy First Step, and he had enrolled and had gone to a couple classes, and then it didn't work out.
Well, I'm really, I can't say happy. No, I gotta say, I just appreciate so much you coming forward and telling your story, because we've had all kinds of people who are kind of providing the treatment, or they're in third-party care. It's all been the mechanics of the deal rather than the actual witness to it all. You've had a lot of courage to come before us today. And I think I had no idea about your husband. Last year, we were working on our bill, and you finally kind of opened up to us and told us exactly why you're so very interested in what we were doing. And I'm really glad that you came before us today to tell us, because it's not easy for any mate out there who has a husband or a wife who's addicted to this. It's terrible, it's very difficult, it's not easy, it's super, super duper emotional, and a lot of times it ends up like you did, a baby, the husband that's gone, you love him very much, and you did the best you could to help him. Appreciate you coming back.
Thank you, Senator. I'm happy to answer any questions.
Any other questions, Deborah?
No question, just a comment, that is echo Representative Heaton, and thank you for telling your story and the courage to do so. I would just add that I think people would be surprised by the number of people in this building who have been touched with this problem and by this problem,
I'm sure.
including legislators and former legislators. And while I don't think it's anyone's responsibility necessarily to tell their story publicly, I think the more we hear from people that we know and very personal human details of what they went through, the more likely that this process is going to have significant positive results. Thank you.
Tom Coates wanted to come and visit with us today. Is he here? Tom is not here? What? Okay, well, he signed up to say something. Right here. Oh, okay, knocked it out, I see. Okay, sorry about that. I thought you were underlining it rather than marking it. Okay, that concludes our work for today. And we begin again tomorrow morning at 9 o'clock. And I look forward to seeing you all tomorrow. Thank you very much for coming.
Yep, sure am. Everybody's agreeing.